Can you hear me, guys?
Yes, we can.
Okay. So, hello, everyone. It's my great pleasure to welcome you in our first day of the Second African Forum of Global Surgery, held under the vital theme, Global Surgery in Conflict Settings. The forum is a collaborative effort between Jazeera Student Surgical Society and the Sudanese Consortium of Surgical Development, SCSD. Together, we aim to create a platform that brings together the students, academics, and professionals in one united hub of learning, exchange, and collaboration. Following the success of our first forum, which focused on student engagement in global surgery, this year's theme emerges from the pressing reality we face all in Sudan. And many other regions around the world are facing it too, actually. Armed conflicts continue to disrupt the healthcare systems, displace communities, and pose severe challenges to delivering timely and safe surgical care. So it became urgent or necessary to address the challenges openly, collaboratively, and with purpose. So we'll begin by framing the challenge, starting by our first panel, research. And in this panel, we're going to discuss how we adapt the methodologies, collecting data, and drawing meaningful conclusions during the instability caused by the conflict. In the advocacy panel, the second one, we are going to amplify voices, defend equitable access to surgery, and influence policy in crisis contexts. The third panel is humanitarian response. And in this, we are going to discuss how we organize surgical interventions, ensure continuity of care, and navigate logistical and ethical dilemmas. Our last and fourth panel is about innovation. And in this panel, we are going to develop context-specific sustainable solutions for surgical care in disrupted systems. So each panel is going to feature experts with real and applied experience in these domains, bridging first-hand knowledge from the field and offering not only insight into the challenges, but also solutions being implemented across different regions. So our today goal is more than academic. It's collaborative, inclusive, and practical. We are all here to learn, listen, and connect. So we invite you all to actively engage and share your perspective and build bridges with others who are committed to advancing the global surgery and even the most complex settings. So thank you for joining us. We are looking forward to a day filled with meaningful dialogue, purposeful exchange, and shared vision. Thank you.
Thank you very much, Dr. Wissam. We will have our next with Dr. Mohammed Sadiq. He is our keynote speaker tonight. Dr. Mohammed, if you can please start.
Hello, everybody. Thank you for being with us today, and I'm very privileged to speak on the opening remarks of this huge work done by the Sudanese Consortium for Technical Development and our partners in Jazeera Medical Student Consortium. So let's start by kicking off and speaking a bit about the Sudanese Consortium for Technical Development. If you are following throughout the years, we started by motivated team groups, starting by working forward to developing the surgical system in Sudan, the quality of surgery. And I've seen some familiar faces among us here, Mr. Kamal and so on. So our philosophy in developing the Sudanese surgical system is explained through our theory of change in front of you. So we have the root causes for the current situation in Sudan is mostly according to the literature and to the documents in our country. The low investment in surgical system is one of the root causes, the current conflict in Sudan, and the poverty, and the pushing factor that leads to the surgical workforce to flee the country to other countries. And our situation at the moment, we have almost the situation is changing all over the time. This was last year. So probably now it's either shifted to the left side more than the last year. So we do have 2/3 of the population, they have no access to surgical care and inadequate surgical training program across the Sudan Medical Specialization Board. And we have a close relationship with them, and we are trying to oversee and support through our departments the training for surgical graduates in Sudan. The collapsed healthcare infrastructure, we do have almost 70% of the hospitals are outside the service. There is a lot of operational challenge in terms of supply and electricity, and Nazar and the team will explore that in their summit. And you do have high burden of surgical diseases in the country at the moment, and there is lack of public awareness regarding some threatening conditions, which our campaigns start to address that. So our change pathways is to change the situation through education, research, advocacy, public awareness, and our work is done through our missions, which is providing surgical leadership trainings through our SCSD fellowship program, and advocating for sharing surgical resource and knowledge, along with advocating for surgical research, mentorship, and quality improvement across the hospitals, Ministry of Health hospitals, and engage with the stakeholders in developing national surgical plans and community mobilization throughout our campaigns, which you will probably observe through our social media. So Nadar, if you will let me to share my screen, I have a very brief presentation about what we can
Yes, please.
take from the conflict. So I will speak briefly about the global surgery in conflict, and this is just brief explanation about our work in Harvard Medical School in the global surgery unit, where we do some mobilization and global studies in across 77 countries to assess the war-related trauma and how people can address that issue. So the burden of conflict on the surgical system is based on the study done in 2015, and at that time there was not a lot of conflict across the world. But according to the 2015, we have 27% of the global daily disability affected at different life periods is linked to surgical conditions. And this 32%, 74% of this is related to surgery, and mostly in communities across the refugee camps. So, and there is some mortality hospital or mortality related to the conflict, which is happening across Gaza and across Syria, and for sure across our country, Sudan. But in Sudan, we don't have like dedicated surveillance system that can tell us. Sorry for that. So in Sudan, the last data that we have is more than 70% of the healthcare facilities are out of the service due to the current atrocity of the bombing to the hospital and the infrastructure of the hospital. So the surgical challenges during the war zones is the main issue is the funding. The funding for the infrastructure, for the surgical supply, for the electricity is the main highlighted issue across the globe. And another thing is the conflict-related injury is more complex, and the fragmented wounds due to the weapons is more extensive and need more surgical debridement and incision of more like 5 centimeter margins and so on. This is by the RCRC. And the 34% of the infection related in Afghanistan was war-related injuries. And the ethical triaging system, which one to intervene, which one to treat first, and where to allocate the resource across. As you all know, that the postgraduate training is the main issue regarding all this. So some potential responses, potential solutions, which are suggested by the RCRC and MSF, because they are the main organizations that work with neutrality without global powers, because they don't have any like governmental funds. So that's why they are neutral in their interventions. That's why you find them in the war zones, regardless of what are the parties fighting together. So ICRC is the International Commission of the Red Cross, and the MSF, Doctor Without Borders, are the main two organizations that can work in the conflict setting without any movement or for supporting a specific part of the parties. So the bidirectional learning is one of the reasons that drive the global surgery to start intervening in conflict setting, where people from high-income countries travel to low-income countries to provide and to learn through the conflict. And the specialized training that's specifically formed to support such a situation are done by the Royal College of Surgeons, which is called Definitive Surgical Trauma Care. And by the RCRC, they have the emergency ward surgeries. Those are two diplomas that's related in training high-income country surgeons to be able to provide surgical system and surgical support in low-income countries. So we have a potential solution or potential response that can alleviate a bit of the suffering, which is the civilian-military integration. It is a model system by our team in Harvard Medical School. We have been working through the last 3 years in formulating a framework where we can integrate the military system with the civilian system to tackle the issue of the access to trauma care and aftercare and the hospital, like for pre-hospital, in-hospital, and the post-hospital care. Because the military, they have the access, they have the resource, they can reach out to the trauma places, but they are less likely to manage the casualty properly and to do the aftercare, like in terms of physiotherapy and so on. So they are the model is we reach out and we interviewed people from 77 countries, and we have a matrix of integration. The only country that has an integrated system is Israel, and the least country that has integrated system are those countries, and partial integration are in the middle. So we observed the three groups of countries, and we went backward, like retrospectively, and to see the situation, why they have less integration, they have high integration, they have this specific integration scope, and what is the difference, and what was the motivation, and what's the benefit from the integration in the countries that they have integration. So the benefit in the integration was part in Israel and with some of the countries that has integration. They have operational preparedness or readiness to most of the conflict situation. We found that 60% of the integrated system, they have readiness to the situation, and it impacts the population by improving their access and resource and supporting in terms of trauma by 64%. And the learning process is similar to the one that we mentioned earlier. And the workforce support, it alleviates the civilian hospital staffing shortage, because during conflict, during atrocity, a lot of staff shortage, and the civilian or the military staff is preserved most of the time. So sharing these resources will help provide and intervene forward. Thank you very much for your time, and if there's any question, anything, I'm happy to answer.
Thank you very much, Dr. Muhammad. Does anyone have any questions for the Dr. Muhammad?
I have just one question, please.
Yes, please go ahead.
Okay, by integration, you mean like civilians, like as a doctor, with the military, like as a teamwork, or as what exactly?
Yeah, by integration, I mean integrating the system itself. Like the military, they have their own hospital, their own staff, their own ambulance, their own infrastructure, and their own supply system. And the civilian, they have their own supply system, their own infrastructure, their team. So integrating both of them, especially in the trauma care, in terms of pre-hospital care, is more likely to provide better outcomes in terms of trauma response. So the military, they show history of being able to reach to the trauma on the atrocity in timely, and being able to transfer casualty to the infrastructure, to the hospitals in a very short time in comparison with the civilian system. So whereas the integrated is in the pre-hospital and the in-hospital. But in the after-hospital care, the military have less equipment, less infrastructure, and less team to provide with the physiotherapy and the after trauma care. And this is where the civilian can take over and can provide the best service to the patient.
Okay, great. Thank you, doctor.
Okay, thank you very much. Any other question? Anyone? If you have any other question, you can either write it in the chat box or just unmute yourself. Okay.
Oh, I see Dr. Catherine here. Hi, Dr. Catherine. It's very nice to see you. Great to see you.
Hi, everyone.
Hi, Prof. Catherine. We're happy to have you tonight. So our next panel will start exactly at 7:20. So if there is no other questions, we can just wait for the next panel.
Hello, everyone. Um, good evening. Thank you for joining us today again in our second African Forum of Global Surgery. This is your moderator, Dr. Tariq Youssef, speaking to you. Joining me, Dr. Nazar, a research deputy at SCSD and an advisor in GS. Hi, Nazar, how are you doing today?
Fine, how are you?
Okay, good to hear that. So today we'll be talking about the first panel of this forum, global surgery research in complex settings. It is well known that Africa has a complex web of, let's say, armed conflicts, with many contributing to low or high intensities of conflicts. These conflicts has significantly impacted the surgical care, and that's due to increased injuries and strained resources, and even potentially destructing the infrastructure of the healthcare system. This ultimately has led to difficulties in achieving fair, equal, and sustainable surgical care. One of the many drawbacks of these conflicts on surgical practice is hindering research itself. Here in our first panel, we are going to discuss this issue with you. But before we go into depth, there are four main objectives of this panel that we need to discuss with you. First one is sharing key differences in research practice between the times of peace and times of conflict. And we need to focus on a very important matter. We need to focus on first-hand research experience. Secondly, we need to explore challenges that face these researches. And we need to focus on three main domains. The first one is local researcher teams. Secondly, equitable collaboration. And lastly, which is very important, is resource limitations. The third main objective is identifying the gaps and opportunities in surgical research during armed conflict times. And lastly, we need to discuss the ethical considerations that are unique to conflict-related researches. Today, we are honored to have our esteemed panelists to cover this panel. First, we have Professor Catherine Chu, the director of the Center of Global Surgery and the professor at Stellenbosch University. Professor Chu is well known of having an extensive research experience, especially in areas where humanitarian crises are very widespread, especially like that we have currently in Sudan and Somalia. Second speaker and panelist is Dr. Barnabas Aliande, an assistant professor at University of Global Health Equity in Rwanda. Dr. Aliande is co-chair of the Center for Equity in Global Surgery. He also has significantly contributed to strengthening surgical system in sub-Saharan countries, like Nigeria. Now we'll have our first panelist, Professor Chu. Professor, could you tell us, please, more about yourself and your experience and what you are going to provide us for this panel? Thank you.
Yeah, thank you very much, Chair. I just wanted to check, can you hear me? Because I struggled a little bit to hear you.
Yeah, your voice is actually very clear.
Oh, okay, thank you very much. Yeah, so I really appreciate the opportunity to speak. I think you did a very nice job introducing me. So I'm going to talk about challenges of research in conflict settings. And I'm hoping that to keep the comments fairly short so we can have time for questions. You can go on to the next slide. So I just wanted to say that both my disclosures and maybe my background in conflict research. So I worked for an organization called MSF, or Médecins Sans Frontières, for a number of years, and I still spend time on a selection committee looking at projects that are both implementation and research, and many of them are in conflict settings. I can talk more about some of those projects that are going on. Next slide. So I think, as both the introductory remarks and our chair has alluded to, so specifically surgery in conflict settings has a few unique issues. So the first is that the injury burden is increased, not surprisingly, but also the access to emergency surgery, or just an access to surgical care in general, becomes more limited, right? So you have two issues: the issue of reaching surgical care, the safety of that. There could be war, conflict, the streets may not be that safe, ambulances may not be able to run. Oftentimes people come in on their own with their own personal transport, and that is no longer safe. And then the hospitals themselves. I think some of the earlier speakers alluded to the fact that sometimes hospitals are only running halfway. A lot of the staff have left because of safety issues. Supply chain is often another problem. Next slide. And then, of course, now the topic of this panel is what are the challenges of doing research in these settings? So, I mean, I think first of all, it's very important to acknowledge that the clinical need during conflict times can become quite high. So then it really becomes a balance between, the few providers on the ground. Should they be doing research or should they be providing care for people? And sometimes I feel, especially working for a humanitarian organization, that the service delivery outweighs the research. And in fact, oftentimes people say that we don't have time to do the research because we're too busy caring for patients. That being said, I think one of the points of this entire conference, it sounds like, and for those of you who are from Sudan, you know that it is very important to report what is happening in the conflict settings. And that could be an argument for why you would do research. But then there are some challenges. Is it safe for researchers to be in those contexts? It's sometimes not even safe for the clinicians to be there. And then the added sort of layer of safety and complexity of having researchers around. And then also data collection tools. And I'll talk a little bit more about some of the other projects in a minute. But how do you establish data collection in the middle of a conflict, especially if you hadn't already had a data capturing system? So to start collecting data in the middle of a conflict setting is sometimes challenging. Next slide. So I wanted to mention that during conflict, the population that needs surgical care sometimes also changes because you have your sort of stable baseline population. This is actually from Darfur in Sudan. And so you have populations who have moved or who are living in a different part of the country than they would have. And sometimes their surgical needs are different than what would have been the local population. I know in Darfur, it's quite complicated because some of these IDP camps have been there for over 50 years. And so this is the local population. But we do need to acknowledge that their needs might be different than a population living in a town, for example. Next slide. And then the other thing in terms of research is that during conflict, there are highly mobile populations, people coming in, people going out, and they bring and they acquire surgical needs that might be different. So with migrant populations, sometimes the water sanitation is worse. So in addition to the injuries, in addition to the emergency obstetrics, you can have people with higher incidence of typhoid perforation, for example, because of the water quality. You'll also have other concomitant diseases like cholera, as well as sort of untreated chronic diseases that make the surgical conditions oftentimes worse. So something to keep in mind. Next slide. So maybe just to talk a little bit about a study I was involved in. It's been a while now, but we did a study in Darfur. And just to say that this was a survey, a household survey of surgical needs within an IDP camp. And I wanted to use this as an example because the logistics of doing research already is quite difficult in certain places, but because of the ongoing conflict and the safety. So I was with MSF. We partnered with Save the Children, who were running, doing some programs on the ground. We had to, so these, there are some people that were external. This was Johns Hopkins University that was running this. But had to be flown in on a helicopter. The helicopter couldn't land because it couldn't stay very long because of the safety of the NGO vehicles that might be hijacked. And so they would drive, we would circle once in the helicopter, the NGO vehicles would come and fetch us, but only to meet us there. They couldn't wait. And then we went back to the compounds. We partnered with local doctors who were working there, but they were from Khartoum. They were not There were no local doctors from Darfur, but we also employed translators locally. So I can talk a little bit more about that because I think part of the discussion is local collaboration. So we were an external team but partnering with local collaborators. Next. So the results of this, oh, just go back one. So the result of this is that we surveyed 800 households, and almost 3/4 of them had had surgical problems, mostly from the conflict. 25% or a quarter still had untreated surgical conditions. So this was a survey, and then as the doctors, we examined both the interviewee and all the household members that agreed to be examined. And they uniformly had poor access to surgical care. I think there was only one place that they could get surgery in Al Janina, and that had to be sponsored by some US actors who were donating money. So there was no real surgical access sort of routinely. Next slide. This is to talk a little bit about MSF, the organization that I work with. It's an international medical humanitarian organization founded over 50 years ago. They maintain themselves as independent, impartial, and neutral. Next slide. Their main mission is to provide assistance to populations in distress and to victims of natural or man-made disasters and victims of armed conflict. So obviously, we're talking about conflict today, but just to say that a big part of what they do is in conflict situations. Next slide. And then surgery is a big part of what MSF does. This is an old slide, but now we do about 100,000 interventions a year, and a third of those are C-sections in about 30 different countries. Next slide. So just to say, conflict, natural disaster are the two contexts where we do surgery. Next slide. So I just wanted to use MSF as an example of how you can do research in conflict settings. It is not the usual way, but to say that MSF with its 30 different countries and about 50 different projects, we had the same data collection tool in every site. It was a very simple, is still an Excel spreadsheet. It's not online. And every month people, the team send in the data. And it was because with this kind of data collection tool, then when the conflict would get worse and get better, the data collection tool was already in place. So this is probably different than a situation where there is no conflict. Then there's a conflict for a few years, and there's the desire to do research and start research in the middle of the conflict. I think that is more challenging. You can click. So this is an example. This was just a audit of about 20,000 procedures, and it demonstrated that we had a very low operative mortality. So this isn't inpatient mortality. This is mortality in the theater, which is an indicator we don't typically use, but that's all that MSF had collected. Next slide. Just go back one, just unclick one. So, go forward one, yep, right there. So another paper we wrote was about surgical care in Somalia. So in Mogadishu, for many years, we would go in and out of Mogadishu, providing surgical care, mostly war wounded. But there were times when the surgeons and the anesthesiologists who were not Somalian would need to be evacuated depending on safety. And so they would retreat to Nairobi for sometimes up to 6 weeks at a time, but the local teams were continuing on the ground. These local teams were not fully qualified surgeons and not fully qualified anesthetists. Mostly it was the scrub nurse doing the surgery, and it was nurses doing the anesthesia. You can click. So using the same data collection tool, we basically demonstrated that when the nurses and the non-surgeon clinicians were performing the surgery, the outcomes were the same as when you had the specialist teams in. And then interestingly, the case mix and the volume of operations was also the same. So they were doing similar types of operations, which in this case was emergency surgery, and they didn't have poor outcomes. But this is an example of the research that you can do in conflict settings because we already had a data collection tool in place. Next slide. This was a editorial we wrote or commentary in the Lancet, talking again about surgical care in conflict. You know, there is a big kind of belief that injury is the main type of operations that we do in conflict settings. But this was just to show that cesarean sections, which we all know is the most common operation in the world, still continues to be very dominant behind injury, even during conflict situations. And I think it's quite important to plan for that, because oftentimes we send in trauma surgeons, but we don't prepare for the fact that women are often cut off from antenatal care. And so there are more women presenting in obstructed labor than probably in non-conflict times. Next slide. And then we also wrote a little bit about when there is a big humanitarian disaster. So this was not from a conflict in Haiti, but from an earthquake. But I think that the response to conflict is similar when outsiders come in and they try to do service delivery, but the response is often not coordinated. And so many groups go to the same place, but in another area, there isn't any support at all. Sometimes the response is too slow. Next slide. Next, you can click. Yeah, again. Yeah, so we made some, I can go back. Yeah, so we made some recommendations for when there is a disaster, how different organizations can be better coordinated. And I think this applies to conflict as much as it does natural disasters, because two of the biggest problems is supply chain and human resources. So the ability to get supplies in during a conflict for their surgical needs, and the ability to organize human resources to come in as well in a coordinated fashion. So we suggested that we form, like, between different organizations, an emergency surgery coalition. I would be quite interested to hear from the people on at this conference how working with the local practitioners can be, because oftentimes in the settings where MSF works, there are no local practitioners anymore at all. It could be quite different in Sudan. Next slide. So in conclusion, conflict changes surgical needs, and it brings new populations like the migrants and the people living in the IDP camps, refugees that need surgical care. Collecting data is really challenging because of logistics, the safety of the researchers, and the stability of the study populations. And I wanted to say, finding the study populations if they don't come to the hospital. And I think it's always important to remember balancing service needs. So operating and taking care of people versus the research is really important. But I do think that research during conflict settings can improve our ability to serve these populations. It can point out a different burden of disease. It can point out characteristics about the study population and their outcomes that could be different, that could really help with planning. Next slide. Thank you very much. And I'm very happy to take questions after Dr. Alayande's talk. Thank you.
Okay, thank you, Professor Chu, for this well-informed presentation. We are pleased actually to listen to that. Now I'll hand the mic to Dr. Nizar, and moving on to our next panelist, Dr. Alayande.
Thank you very much. Thank you very much, Prof. Chu, and thank you, Dr. Tariq. We will have our next part of this panel with Dr. Barnabas. He's a specialist general surgeon. He's also an assistant professor of surgery and the co-chair of the Center of Equity in Global Surgery and the director of the Masters in Global Health Delivery, especially the global surgery part. So, Dr. Alayande, if you can please share your screen. Go ahead. You are on mute.
Let me know if you can hear.
Yes, we can hear you now. Yes.
Yep, you can hear me?
Yeah.
Awesome. Thank And I hope that it will be clear enough for you to hear. So we just want to explore some challenges and then propose some strategies to strengthening surgical research capacity during armed conflicts. And we're looking at gaps, barriers, opportunities. And again, I'll keep this short based on the guidance of the team so that we can have time to really discuss. And I'll focus this on a case study. Prof. Chu was talking more at an institutional level in terms of research in conflict settings that, with the whole institution backing you up. I want to come from the perspective of armed conflict in which there is individualized personal research, right? You don't essentially have an institution behind you, although you may be part of an institution. What can be done? So I did my training somewhere in northern Nigeria, at boundary where there's some armed conflicts. There's some activity of Boko Haram, activity of several herders versus pastoralists versus farmers clashes. And so it was just consistent that through the time of my training, there was this exposure. And where I was, we started the first like trauma division within that region and eventually worked on mass disaster, mass casualty plans. There are times that you'd spend a long period of time in the hospital, a number of days because of certain geopolitical, religious, all sorts of crises, economic crises that were going on. And in this same space, I had the privilege of doing the Safe Surgery Organizational Readiness Tool across up to 500, 600 facilities, many of which were in rural areas and steeped in the sites and locations of conflict. There were safety issues around that. Also looked at the surgical access to availability and how prepared surgical assessment to use the World Federation for Societies of Anesthesia to find out how prepared people were to provide anesthesia and what was going on there. And then the WHO tool, which is called the HEAT tool, Hospital Emergency Assessment tool, also within this space. We also went to the communities and went house to house in a number of villages to identify community-based burden of disease. So I've had the privilege to do this within the Nigerian space and also had some experience in South Sudan with some of our work there, identifying again the readiness of facilities. So again, this is more independent research than institutional. And because there's a high burden of surgical conditions in conflict zones, there's a distinction, there's a difference. We'll talk a bit about that. And we'll talk of the role of research in improving the outcomes. This work was Sure on this seminar was the manager of a lot of the work on the ground, but we will talk about some of the lessons that we learned through this and in this space. So I will just go quickly to highlight, for instance, that there's so much that was going on within that space, within the time that we studied, and we had worked within this space, going from location to location. And well, the thought was, regardless of what this crisis is, there's a need for a solid foundation of surgical data. It's best buy for interventions, right? So regardless of whether or not there is conflict, there is need for data. There's need for clear data to drive data-driven decisions. And without that, right, we can be at best throwing dice, guessing. And if there's going to be policy shift, even within those spaces, concrete clinical action, identifying of surgical deserts, a lot of policy advocacy, even receiving help and support from other contexts. There's this story that is told by data in addition to again, coming back to the words of somebody who was a minister from the Ministry of Health of one of these at the Pan-African Surgical Healthcare Forum, I believe that was 2 years ago, where there was a lot of talk about developing surgical plans. And he said, look, our primary thought is for security and safety. And so that is what we're going to put a lot of our resources on and then when that is sorted out, then we can focus on surgical care. But it's a chicken and egg thing, because once there is little or no focus on surgical healthcare or even surgical research to be able to tell the stories, then the health of individuals are neglected, and then the conflict just goes in. It's just a vicious cycle. And so I would jump a lot of these thoughts. We had the privilege of doing something multi-method, right? And it was largely observational. But the first thing I would say in terms of working within these settings on an independent and local levels, that you need to build a team. And that team is best made up of people who know the terrain. At certain times, they'll say, don't travel here, don't be here, don't be in this space, things are going on. If you had no idea, you would walk head on into a crisis situation. And so I think the concept that the best research that can be done in conflict settings comes from within those conflict settings is something that we have to pay attention to. Then, things are not always the way they seem. On large national registries, you say, oh, there's this facility here, there's this facility here, there's this facility. What we found when we were able to enter into certain of these facilities was that there were discrepancies between national facilities and then what was on the ground. Some of the facilities were locked up because of the issues that were going on, right? And so I think that it's more of, in some of these settings, a lot of the things we have are based on assumption rather than based on hardcore research. So eventually we gathered about 150,000 data points, and we surveyed a number of them. But you will notice, I won't go into a lot of the core details, but you will notice, for instance, that less than 2% of people had funding their facilities for surgical research. I will jump a lot of the specifics because I think it's the ideas or the thoughts and the lessons that we really wanted to focus on. And so some of the core lessons that we learned through this was that in order to advocate for surgical care, there's this tension that Dr. Chu talked about. In order to advocate for surgical care, there's the power of the data, the research. That in itself is something that is needed because people need to know the story of the conflicts and the things that are going on, right? So that in itself was needed. For a long time within one of the settings in which we work, there's been a neglect of surgical care in these rural populations. But we're able to write clear recommendations to the Ministry of Health, and they saw that the state of surgical care within these settings, and we also were able to tell them, oh, these are the facilities that can be upgraded, these are the facilities that are working. So there are gaps. We see the gaps of limited research culture. Again, it has been mentioned that there's this tension. Should I be providing care or should I be collecting data? But my thoughts are that the data tells a story, and so it can be both, right? Even though we tend to prioritize one over the other, there's an embedding of research in everything that is done, all the care that is provided, so that we make things count twice. The second thing we find is that there's lack of structured research programs in these areas, right? There's minimal integration of research within humanitarian and or military medical mission because it's largely focused. But we've seen MSF and the work that is being done and the integration of some research in it. But generally speaking, that is not what is termed to be the focus. And that's something we have to think about. If you look at the data, there's underrepresentation in global literature of this. So I drew some columns that tell us what are some differences between places of crisis and places where there's no crisis. Acute trauma, emergency procedures, the morbidities that come with humanitarian crisis, overcrowding, what happens in camps, that's one research focus. And that can be maximized. We can look at that and tell those stories versus peacetime, where we can concentrate on elective surgeries, some outcomes. There's a lot more infrastructure that is established in peacetime. And so we can collect data through established infrastructure versus where that is damaged, where that is absent. There tends to be more fragmented paper-based data systems when we're collecting data. And I'll show you a pile of papers that we used in one location versus digital, standardized, institutionalized, etc. But the flip side of that is that digital means IT, phone calls, all sorts of in artificial intelligence, all sorts of gadgets, those things can actually help us collect data where we cannot go in some of these conflict settings. And so for some of our walkthroughs, we did virtual walkthroughs where an individual who already has access to the facility puts on their phone and they go from place to place and identify what the things are. Ethics review is another concern that in some conflict settings is not available, right? Versus where it's institutionalized. And so that gives us some thoughts about, where can we go to get ethics review for this particular study in this crisis situation? What of staffing, right? They're transient teams. So the people who were here today are not there tomorrow. Another set of people come tomorrow, and then the project may be something longitudinal. And so that you have to really think about that and see how you can make short wins and kind of integrate the longer term research that is injured, or somebody who steps back from the time of crisis. So this, I just put the picture of this paper-based data collection that we did at certain of the sites, and you can see that it is quite a lot, but it involved a series of, collect data from here, transport it in a safe way to this location, transport to this location, etc. And some of the people that we worked with have been able to step forward to other things. So these are examples of data based and data collection, which is solidly paper-based. So there are some key barriers, ethical regulatory challenges, which we've mentioned. And then there's this concept of politicization of data. We have to be careful that, and Prof. Chu was talking about a neutral organization going there, but the data can be politicized. And the essence is, why are we doing this? Is it for the patient, or is it to create a wider wider crisis? Again, people may not trust what you are coming to do, especially if you are coming from, and that's why we said it's the best people who can do this research are people who are integrated and within these communities and working within these communities. Story or to spin story that and we need to think about that. What of access to quality data? Most patient records may be fragmented or lost due to displacement. Follow-up capacity is not so strong. Some people may not be able to come back, right? You may not be able to follow up patients a long while. There are some situations where people cannot access the facilities, or facilities themselves are destroyed, etc. And lack of interoperability of digital health infrastructure. What of infrastructure limitations? Phone calls may not be able to go through IT, data storage systems, insecure environments, etc., may limit research continuity. And then funding. Not many people want to fund research primarily in a conflict setting. People want to prioritize service delivery. And so we have to think of how we can integrate this, even if that kind of funding is not available. And people also would think, for instance, we got some funding to do some research in one of these settings. The deadlines kept being pushed back to say, hey, people cannot access these facilities. We will not allow our teams to be in unsafe spaces and time. So please, can we have an additional month? Then please, can we have an additional month? So some funders are looking for results quick, and so there may be not too much dedicated research funding for conflict settings. And then academic institutions usually partner together. Has been relocated, or there's no academic institution within a space, right? So we have to think about that. Now, there are some models that we have seen, some issues, but I'll jump straight to the recommendations. Can we embed research protocols into humanitarian missions? Is that a possibility? Can we move to such a way that there is an embedding already of research? Can we establish some kind of regional ethics committees go from place to place for rapid IRBs in some of these settings? Can we strengthen collaboration between NGOs and academic institutions to do research within these spaces, and then ministries of health, and then prioritize building local capacity so that the people who are in these conflicts are the ones who can collect this data, who can write these things up, who can do that? And then can we think of perhaps cloud-based tools or digital tools and platforms where sometimes you cannot travel across with whatever you've collected. So digital tools also could help if there is internet, if this is available. All right, so those are my initial thoughts so that we can have some discussions. Thank you very much.
Thank you. Thank you very much, Dr. Alayande, and thank you, Prof. Chu, for your presentation. Now we're going to have the questions. If anyone have any question, please write it in the chat box so I can ask it to the Prof. Dr. Alayande. So I might have some questions for both of you, but I will start by a question about the Darfur study that Prof. Chu mentioned. You mentioned that you were moving from place to find the internet displaced persons, but how could you manage to do that? What tools have you used to find them? And especially that you mentioned that they are also moving, so they're not in the same place all the time. So how can, in such situations, especially in Darfur, how can we manage to do that? I think maybe Prof. Chu has some issues with the internet. Okay. Meanwhile, I want to ask you also, Dr. Barnabas, about the things that you have mentioned. So I think, can you hear us, Prof. Chu?
Yes, apologies. My internet is going in and out. I'm just going to move so I can be heard better. Apologies. Can you still hear me or no?
Yes, I can hear you. Yeah, clearly.
Oh, okay. All right. Let me try. Continue to try.
So we were asking about the Darfur study that you've mentioned.
Yes.
So you said that it was kind of hard to follow the internet displaced people, that they're moving from place to place. So what tools have you used to do that, and how can we do something similar, especially in Darfur, that many of the populations, the indigenous people, are moving from place to place, especially if the conflict now is arising even more and more?
Okay. So sorry about the internet. So the IDP camp study, because people had sort of been living there, or there were different households, we kind of used a GPS mapping, and we just randomly selected multiple different households, the 800 different households, based on sort of a map and the different structures. And then we used the definition, who slept there last night, as the definition of who is in that household, because people coming and going, and maybe not everybody sleeps in the same household that night. For the migrant populations, it is more difficult because sometimes the camps are temporary, but you can still do household-based surveys there. Because sometimes the camp only lasts a year or so, but then you can still do that. Maybe just to point out, I think everybody on the call will understand that if you do a survey of patients in the hospital, and they've been taken care of, that is the survey of the met need. But if you go and you're looking for the unmet need, so Dr. Alayande was also saying when they were doing household surveys, then you're looking for the unmet need. And that is much more difficult for the reasons why you were saying it, to go into the communities. Also, going into communities, I think it is just very important to stress knowing the local context and having local connections. Again, Dr. Alayande mentioned that as well. But, in our case, knowing the local chiefs, even in an IDP camp, people had organized themselves into their own social structures, and the sensitization of why we were there, because people can be quite suspicious. Like, what are you doing? I once did a questionnaire about people's views on organ transplantation. And of course, that was interpreted as that we were trying to take their organs. And so in hindsight, that was a very naive study to have done. But I think that for the migrant population, you have to go looking, because sometimes people are also, hiding, especially during conflict settings. They don't want to be seen. And so you may not be able to sample everyone.
Okay. Wissam also asked in the chat box, you said, to what extent do you think the data collection in the nearest non-conflict zone is representative instead of working in the conflict area and as a solution to the issue of prioritization? So, Dr. Barnabas, we can go with that, then we can go back also to the report.
Yeah. So I think that yes, it's more secure, it's more feasible. You're able to capture the displaced population. But I think that it will give us good but very incomplete data. The limitations are that there is going to be selection bias, right? You're already dealing with people who are probably more mobile, probably have more resources, are able to flee to neighboring areas. They're usually more resourced, sometimes younger, sometimes more healthy, as compared to those that still remain. And so in my opinion, I think you may be missing the more vulnerable groups, those that may be disabled, those that may be elderly, those that can really give you a well-rounded picture of what is going on. And then there's also this concept of survivorship bias, where those that are outside, they're by definition, they are survivors. They are often they've had long delays, or often they've had severe trauma, had the opportunity to be able to go around, and the care systems are also different. That said, I think it's still a pragmatic way. Doing some work in South Sudan, we had this concept of missing out a couple facilities. Initially, we wanted to go to this number of facilities, but all of a sudden things broke down. Within 2 weeks, we were unable to access these facilities. Still use the data from the facilities we're able to access, but it's definitely not the same. And then there's some policy disconnects. There may be refugee health planning outside the core conflict zones. But maybe not national health system recovery or some post-conflict surgical capacity building. So you're looking more at much more at vertical systems and where they are. So I think that we should use that data. That probably is what we have available, but we should not rely exclusively on that data because we may skew it. Sometimes people use remote methodologies to deal with that, right? So you take the data from here, but you're able to call in, you're able to video in, you're able to get some data and then use remote methodology so you have better rounded data, or you use some kind of community-based reporting from within the conflict zone. Qualitative work too can be done. Or once you have access, you combine some retrospective studies with whatever you are doing. Over.
Thank you, Dr. Barnabas. Do you have anything to add to this, Prof. Chu?
Yeah, I mean, I think as Dr. Allende said, it's the balance of logistics, right? I mean, I think that surveying or doing facility assessments and looking at the population at the edge of the conflict may be vastly different, but if that's the best that you have, that's important to think about. I also wanted to touch on the issue of the challenge of ethics, because sometimes, for example, in Darfur is still a part of Sudan, but for all intents and purposes, there is really no Ministry of Health functioning in Darfur, at least at the time we were there. And so for locals and even for us from outside, trying to get ethics approval is very challenging. And sometimes I think individual researchers, contact me and say, okay, we want your help, but it's the local ethics that are the hardest, because there either isn't a structure or it's very delayed, or they're not interested. But I think that making use of contacts on the ground, so if there is a functioning healthcare system in any which way, there will be local practitioners, and they may not be surgeons, but I think if there's any possibility of pulling them in instead of bringing people from the outside, that would be really helpful. But most times the issue is the funding, and the funding often comes from outside the country, because if there's ongoing conflict, it's often not the priority of choice to fund research about surgery in a conflict. And so sometimes outside organizations want to bring in their own people, and so that brings sort of more logistics. The other thing is kind of difficult to apply sometimes for funding unless it's an ongoing acute on chronic conflict, because some conflicts just arise and then at that point, you don't have any funding. But there are certain hotspots, and certainly Sudan is a good example now, Central African Republic, Eastern Congo, where there's always conflict, and so you can perhaps slightly plan better for it.
Okay, that's true. I think also someone asked about the training programs in global surgery. So I've asked Prof. Chu and Dr. Ali, and they have answered you. They offer a master's degree in both the University of Global Health Equity and Stellenbosch University. So mentioning that, can we maybe have in the future, can we have like a collaboration with the Center of Global Surgery with both of these, both of you in both universities, especially that we're launching a global surgery lab in the SCSD, the Sudanese Consortium for Surgical Development. So we will be working on research projects in Sudan specifically. So I don't know if maybe we can have some collaborations in the future. Okay.
Definitely.
Thank you very much. So as you've mentioned, there is some dangerous situations that comes with the conflict. Prof. Chu mentioned that in Darfur, for example, the Federal Ministry of Health is not there because there is a conflict. I think there is an attitude for the Federal Ministry of Health to leave the hospitals that have conflicts in Sudan, and many times they just leave them completely, and they said we cannot control the hospital, so we will not provide any help there. So one of our projects, we had the mass casualties research, and we sent one of our research officers to a hospital in Omdurman, in Khartoum, and in the day that he went there was bombing in the hospital. So he might be one of these mass casualties. I want to ask you, how can we deal with these dangerous situations that often happen in research in conflict zone? Prof. Chu, can you start?
Yeah, sure. I mean, I think, my experience is very different than Barnabas's, because I came with an organization, but with MSF, the safety of all the workers is paramount. And so, yes, we do feel like research is really important, but if there needs to be an evacuation, the research team goes out before the clinical team, but often together. I think that it's quite important to build local capacity, because oftentimes locals don't get the option of being evacuated out. Sometimes they also do for short periods of time and then come back. But if they know how to collect the data, or they know how to conduct the surveys and continue with the survey tools that are going on, I think that's the most important, because they're likely the most resilient, or the ones that stay behind. So I do think it is quite important, if you come in from the outside, to build local capacity. Also, oftentimes local clinicians or researchers, medical students are also very interested in the research, so that they never had the opportunity to learn about the methodology. So I think that can be also a win-win. But it is dangerous, and I think you just have to balance that. It's no use doing research if you're going to get yourself killed. So I think your own safety is probably still paramount.
Yes. Thank you very much. Dr. Barnabas, okay, you've
Yeah.
mentioned,
Okay.
Dr. Ali, sorry for interruption. You've also mentioned that you had a part of your training in a conflict zone where Boko Haram and other groups were active. So how can we manage to do that also as well?
Yeah, I think it wasn't the most pleasant experience. I remember the first time and when I came into Rwanda, there was a night that they were doing firecrackers outside. I put off all the lights, put the children in a room. Everybody was quiet. I called my dean. I said, I'm hearing gunshots. He said, you may want to take the kids outside. When I got out, I saw it was firecrackers. So it's not as if it was a very pleasant experience, but I think it kind of prepares you to be adaptive. So you can operate in this way, and then if certain things happen, then you operate in a different way, and there is some value there's some value in it. Like Dr. Chu said, regardless of what it is, you don't want to be collecting data and then you have both yourself and the data are all gone, right? You want to be sure that your team is safe. So sometimes we would sleep in safe areas, and in the daytime within light, carefully guided with collaboration with whoever is available, we would go to certain sites, some of which you could only get to on motorbikes, right? And then you would come back. And so the entire team was kept safe. And I also had very strict policies with the team that after 4 p.m., for instance, wherever you are, make your way back to this center. So kind of having the local pulse, being certain about safety. We collaborated with the military. The person who was managing our team was serving around that time with the Air Force. And so there was an Air Force base that he was focused on. So somehow just thinking about the security of your team and making sure that that is paramount above anything, such that even when we were reporting back to funders and saying this is what we did, we clearly told them there are gaps in the data here, and these are the reasons because of security. I think that regardless of what we do, we should make sure that we're thinking about the individuals who are working there. Over.
Thank you very much, Dr. Barnabas. Prof. Chu, there is also a question for you from Wissam. She's asking that she's facing some issues with communication with the local doctors. Even when they go to a conflict zone or near conflict zone, they feel like they're outsiders or intruders. So how can they manage to get the data from these places?
Yeah, I mean, I think that I mean, whether you're in a conflict zone or not, it's pretty difficult to do research if the local team doesn't feel any buy-in or ownership. And I think that is something that as a research team, you have to work on. And I don't think you can do research in a place if the local teams don't feel any ownership or link with you. In fact, I think you'll be seen very much sort of as an outsider. And I think all of us need to be careful not to kind of do helicopter research where you fly in, collect your data and fly out, whether it's in your own country, but in a different province, or you're from the academic setting and you've gone to a rural setting, or if you're coming from one country to another. Because I do think that, yeah, I mean, if you're from an area, they're not your patients, but it is your community. And, sometimes even if you have the best intentions as an outside researcher, I think it's very difficult to proceed. In fact, I don't think you can if you don't have the buy-in of the local clinical manager or the local head of surgery or, the village chiefs if you're going to do a community-based survey. Yeah, I think, it's up to the powers of communication and persuasion to explain why your study is so important. I think really that's the most important is, if you feel very passionate that this is going to change their lives and their practice, then we must try and communicate that. I know it's easier said than done sometimes, but yeah, I think otherwise it's challenging.
What do you think about that, Dr. Rani?
No additional thoughts, really. I think it's very well said. Thank you.
Also, I wanted to ask you about how can we use these data to implement change? And often we have a lot of data, a lot of research, but what can we do about this data?
I think that there's a lot that can be done with data, but the challenge is for many academics and many people working in this space, we stop at just some academic publication and that's it. I think that a lot of that needs to be translated into opinion pieces. A lot of this has to be translated into policy briefs. A lot of this has to be translated to things and then made available to the individuals who need the data. For instance, when we're studying and getting permissions from the Ministry of Health in one particular space, it was very clear. We said we will send back a report. It's expected, right? But we said we would send back clear reports, we'll bring back clear recommendations. And the person noted, the head of the M&E noted, he said there are many people who come into this place and never give us a report. Right. So I think that we have to be deliberate about taking this data and making it available to individuals who can use it to create some kind of change and to think about people. Then I believe centering individuals, centering the patient in what we believe that the data should, it's not just what is the message you are trying to pass across, right? It's about global surgical care, availability of safe, affordable surgical care, for instance, in this population. And so whatever we're making available, whatever we're thinking about should be centered around that and not around fueling further conflict, etc. That would be my take. And then we can use this data by pairing it with stories. People, on one end, we need data, but on the other end, we need like stories. If you pair that with a specific story, and then you have opinion pieces around what can be done. Data, the patient, and then putting it in front of whoever needs to see that. Over.
Thank you very much, Dr. Anandi. Asma, if you can please explain your question. She was asking, how can I solve the problem of the lack of previous scientific research on a topic in database? So I think maybe she's having like a novel topic and she cannot find it in any database, something similar to that. So what do you think, Prof. Chu?
Sorry, Dr. Nazar, I missed out your first part of the question that she couldn't find what?
She couldn't find previous literature or data for her topic, so in the database. So what can she do in this situation where there's no previous data? I think maybe can she also explain more?
Oh, like she's done a literature search on her topic and she can't find any other literature on it. Well, I guess it's either possible that she's come up with a very unique topic or that she might not be looking in all the right places.
Yes.
Yeah. And so
Okay.
yeah, I would kind of add that it could also, a third possibility would be maybe she doesn't have the tools to look in the appropriate place. I know that for many of us in low middle income country settings, our library access is not as robust as getting something, from a Harvard or from an MIT or from, somewhere. So I think collaboration, if you have other learners, other students that are in certain facilities, that are perhaps in HICs and have access to libraries that are much more robust. You can talk with them. There's also this Hinari project, for instance, that gives us access to. So being creative about access. What I do sometimes is I just cold email or cold ResearchGate message people, right? That you get there, you can message and say, I need a copy of this paper. But if you have not found it, perhaps it might be the tools that you're using to search. And second thing is, if you're looking for local studies, you may not find them the same way online, right, as you would find international studies or certain studies there, because there are some journals that are not predatory, but they do not have like the kind of stuff. They may not be PubMed indexed, they may not be on Scopus or something like that. They may just be, so you may need to talk to individuals, talk to journal editors. Prof. Chu, I know you probably agree with me that it's hard for you not to find any literature at all about a particular topic. So I think the librarian, because they're trained to search. If you can find somebody who's trained to search rather than just doing it on your own, you can link up with the librarian and look out for this.
Yeah, I mean, I think it's also possible that if the topic is about doing research during conflict settings, you might not find anything, but I think it's then important to look for other studies to find what the methodology they use that could still be applied to your study. Because I think that sometimes I find when you're starting out in research, and even when I'm doing research, like I know the topic I want to research, but I don't know how to go about it. Like, I don't know if I should do a survey or if I should do a qualitative study, and like, if I want to do a household survey, do I do 5 households or do I do 800? And reading other people's studies, even if it was about diabetes, but it was in an IDP camp, it can give you a lot of ideas of how to move forward. But as Dr. Alayanda said, I think looking people up on ResearchGate and just emailing them, like, you know, sometimes you have to send a lot of emails to get a response, but I do think that is a good way to establish collaboration.
Thank you very much. We have only 1 minute left. I want to talk about the thing that you mentioned in the chat box, Prof. Catherine. You said there was a discussion about the certified and non-certified surgeons. So in some areas we have, especially in rural areas, even in conflict or none, we have people, doctors that they have no access to specialized doctors to do referral. You have some experience with that. You made like a referral system using WhatsApp in South Africa. So can we use these things to make it better, maybe?
Yeah, I mean, I think that if you want to have non-specialists do surgery, sometimes we call that task shifting. Task sharing is more ideal when there's a team, and maybe the specialist who should be part of that team is virtual, so they or they are on the end of a WhatsApp call. It is more ideal when the specialist can spend time with the non-specialist training. So in Somalia, for example, you know, by de facto, as the specialist teams came in, they trained their the scrub nurses and the nurses there to do the anesthesia, because they knew that there would be times when they would it would be gone. So by necessity, but it was quite a, you know, it was almost like a residency program. I mean, they had the non-specialists doing the operations while they were there. So when they went away, the other team would still be able to carry on. This is back before we had WhatsApp, so they didn't really contact one another. In the worst case settings, you know, it is good to have someone on the other end of a WhatsApp, but it's quite important that they know your skills, and so they can assess how to coach you. Because oftentimes in a conflict setting, or even in rural settings, there's no way to refer the patient. If there was a way to refer the patient, that's as likely the safest if you've got a doctor who doesn't have any surgical skills, or you have a non-doctor, you know, a mid-level provider who has no skills in surgery. I think that, to me, it's really about the competency than it is about the letters after your name. And so I'm not sure you can coach somebody who's never done surgery on WhatsApp how to do surgery. At least I don't think I could. But if you've spent time with the person, you know their skills, and you've discussed sort of what they could potentially do, and then you're no longer there, the specialist is no longer there, but having the specialist, you know, kind of being able to consult from afar, I think is an option. And I think in these days, that's happening more and more. Even when I worked with MSF, we often had a pool of very experienced surgeons working from all over the world that we would all ask advice for. You know, I've got this child, there's no way to do a workup, I can't get an MRI, there's a huge swollen abdomen, here are the vitals, you know, what would you do? And then there's also sort of the technical questions. I've now got a tumor encasing the inferior vena cava. What can I do? You know, so there were sort of two types of questions: management questions and technical questions. And so I think we all can use that virtual consultation, but I think that it would be difficult and challenging to be talking someone through it who had never done it before.
Thank you, Prof. Catherine. I think that's concluded our discussion. Dr. Barnabas, if you have anything to say before we finalize.
Just to say thank you for bringing us on, and that I see that it's very, very wonderful team of people. Hope to be able to connect and see how we can share resources. And again, a plug-in for the Masters in Global Health Delivery, particularly for people in conflict settings. We do have scholarships, a set amount of scholarships every year that is fully funded. And so I'll encourage you to keep an eye on the website for UGHE and do an application next year. Over.
Thank you very much, Dr. Barnabas. Thank you, Prof. Chu, for coming tonight. We're very happy to have you. Thank you, everyone, for listening. I think now we will go to the next panel about the advocacy in global surgery. So
thank you. Bye.
Thank you. Goodbye. So everyone, we're going to proceed with the advocacy in global surgery panel. Please stay with us. Ilaf, would you like to share? Should I share the screen? I think you'll be sharing the screen. So, Dr. Katun, we're very happy to have you.
Hello, thank you so much for having me. I apologize for not being able to join much earlier, but it was wonderful to catch at least the end of discussion between Dr. Chu and Dr. Alayande. Thank you for having me to be a part of this wonderful event. Excited to be here with all of you.
No, it's totally fine. We're very happy to have you tonight. You bring too much joy to the panel, so we're very happy to have you tonight. So Dr. Katun Madani is founder and executive director of the Semerge Global Surgery Collaborative. She's also, she have her first MD in Anderson Fellow in Global Surgery, Policy and Advocacy at the joint program by Baylor College of Medicine, Center for Global Surgery, and the Baker Institute for Public Policy at Rice University. We've worked previously with Dr. Madani, maybe in Incision Global. So there's that also. We're very happy to have you and listen from you tonight. Would you like to start, or maybe we can start with our surgical landscape in Sudan? Would you prefer? Should we start, or you would like to do?
I am flexible. I am happy to share screen if I have the privileges to do it, please.
I think you do, yeah. Please share.
Thank you so much. Is my screen visible?
Yeah, we can see it clearly.
Perfect. So from what I caught at the tail end of the discussion from Dr. Chu and Dr. Alayande, you may have a lot of overlapping discussions today between all of us. I have not made this a very long presentation because I wanted to allow time more for questions and answers. In context of conflict, I want to share that my personal experience has been through being chair of Incision, leading an organization that had members that were in areas of conflict during my time. We had multiple areas of conflict within national working groups of Incision, and it posed a challenge as to how we best address and support our colleagues in that area. With that in mind, I'm gonna tackle the issue of advocacy a bit more. So from a historical perspective, whenever we talk about conflict, I think it's interesting to remind ourselves that conflict and war, as unpleasant as it is actually a medium for improvement of surgical techniques. It has been throughout history. In fact, there's a quote that is attributed to Hippocrates that says, "He who wishes to be surgeon should go to war." My apologies to all my women surgeon colleagues that at those times, I think they only considered men as surgeons, but essentially the core of this quote is that in war, there was a lot of opportunities for surgical techniques to develop and improve because it was a life-saving moment that they would do amputations and a lot of other procedures at the time that they didn't have access to antibiotics or anesthesia, medication, and so on. Many of our modern improvements in surgical care, especially in trauma care, also come from conflicts. For example, the massive transfusion protocols that are in use in a variety of countries in the world right now are actually products of Afghanistan and Iraq wars, and the trauma surgeons that were behind developing those techniques are veterans from those wars and served during those times. In terms of the perspective on war, I think there's two schools of thought when you look at the literature. One is centering surgery as a necessity to support the armed forces that are going to war, the military. And then the other aspect is in humanitarian side of the war, in taking care of casualty and patients and so on. With that in mind, I thought that was interesting to look at the historical perspectives for International Committee of Red Cross and acknowledge the fact that actually Red Cross is older than World Health Organization itself. And the World Health Organization is almost a century younger. And so our idea of coming together for healthcare it really came a century after our idea was initiated for the need for care of the injured and the wounded during the conflicts and wars. Looking at what are the organizations and conflicts that are involved, I think it's important to talk about some of the global level mechanisms. The WHO's Health Emergencies Program is one that comes to mind. The goal of this program is to prioritize global health security by preparing for preventing and detecting and responding to disease outbreaks and other health emergencies. That includes essentially disasters that are natural or man-made, including conflicts. There is a emergency response framework published by WHO that you can access actually online for free. And within that framework, it's like a slide presentation or a PDF, if you will. There is a sort of a diagram that I have shared here that shows that conflict falls under two agencies, IASC and OCHA or OCHA leads. And it's interesting to see from there, it goes through risk assessment, event grading, and IMS and response. So what are those two agencies, though, who they are? And the reason I'm going into this is that if we are to advocate effectively, we need to understand the landscape of who are the players that we are advocating to and needing to support. So United Nations Office for Coordination of Humanitarian Affairs, known as OCHA, collaborates essentially to deliver life-saving humanitarian assistance in disease outbreaks, natural disasters, and complex emergencies, which conflicts fall under. And it does that in support with two different funding mechanisms, one through Central Emergency Response Fund, the other one through the country-based pooled funds or CBFS. If you look at the diagram on the right, it shows you essentially the top 10 contributors for 2023, and it's in US dollars in millions. And you see who funds essentially these activities and who are the players in directing those funds if you are to advocate to them. The other agency that was named on those slides is the IACS, which is Interagency Standing Committee. This was created by the United Nations General Assembly Resolution 46182 in 1991. It is the longest standing and highest level humanitarian coordination forum at the UN systems. This brings together executive heads of a variety of organizations, 19 to be exact, and they have a consortia to formulate policy, set strategy and priority, and mobilize resources in response to humanitarian crisis. And they also advocate for common humanitarian principles and making strategic policies. So this is another agency that could be the target for advocacy or outreach when conflicts arise. Now, what do we have by the way of WHA resolutions? Of course, there are many that target the issues of conflict and so on, but within global surgery sphere, when we speak specifically about global surgery, WHA 76.2, also known as ECHO resolution, which talks about integrated emergency, critical, and operative care for universal health coverage and protection from health emergencies, actually does mention conflict directly. This resolution really builds on 6815, the first resolution that was focused on surgical care, and 6815 really declared that surgery and anesthesia, emergency surgery and anesthesia care were components of universal health coverage, and they should be included in every health systems. And this resolution that we are looking at, ECHO resolution, builds on that, looking at health from a perspective of a security measure, and talks about a continuum of care for emergency, critical, and operative care. And if you look at that, it acknowledges the need for sustainable development goal aligned improvement of surgical systems, and does recognize fragility that comes from areas of conflict. And it has even in the component that is directed towards the member states a clause for conflict. So for those of you who may not have read this resolution, every WHA resolution essentially is a handshake, an agreement between the World Health Organization and its member states that are essentially forming it. And WHO has 194 member states that it works for. So the member states are the boss at WHO. In every resolution, what happens is that we have a discussion of an issue, and then we have roles and responsibilities for the Director General and the WHO, and roles and responsibilities for the member states. Here, in the resolution, the member states are essentially urged to promote more coherent, inclusive, and accessible approaches to safeguard effective emergency, critical, and operative cares in disasters, fragile settings, and conflict-affected areas, ensuring the continuum of provision of essential health services and public health functions in line with the international humanitarian law. So resolutions themselves are not legally binding, but this resolution is tying the requirement of support for healthcare in these conditions to international humanitarian law, which is legally binding. Now, since then, within global surgery, there has been a consensus framework developed. This is an open access article. You should be able to have access to it, which essentially it was a framework for humanitarian surgical response to armed conflicts in 21st century warfare. It's a framework that was developed to provide a standardized approach to minimize preventable death, disability, and so on, with consideration of the surgical needs of the population during an armed conflict. This is an interesting framework in that it divides the response to multiple levels. First is community first responders, second is trauma stabilization point. Third actually is divided to subcategories of definitive care facilities, contingency facilities, and advanced capability packages. And the fourth is reconstruction and rehabilitation, which is at a later time. Here I have for you an example of what the reconstruction and rehabilitation services should look like. And as you look at it, they divide that into minimum requirements, and it lists a set of procedures that should be available, and then context dependent, and another layer of not to be performed, not exhaustive, essentially, for the first layer of response, right? All of that said, in conflict situations, we have barriers that are quite significant to surgical healthcare delivery. There are multitude of articles and papers published on that. I found one that was directly discussing the impact of the conflict in Sudan to healthcare system. And you can find similar articles about other areas of conflict. I know that there is one at least very well written for Ukraine and another one for Gaza. These barriers go to different sort of levels of what is required for surgical care delivery. In terms of infrastructure, water and electricity and supply chains may be disrupted if the facilities are harmed or if the city infrastructures are harmed. Workforce, you may be dealing with a situation that there's pre-existing shortage of workforce, and now it's compounded by the impact of conflict. Either the healthcare workforce has left the area for safety reasons, or they themselves have been injured and, or God forbid, killed in that conflict. And the other factor that's quite significant is nutrition, because it not only impacts your workforce's ability to continue, because we all need to eat, but also it significantly impacts patient recovery. We all know that surgical patients have a post-operative period that is critical for their recovery, and if they are malnourished to begin with, they are nutritionally behind, it will be very, very difficult to essentially carry out that recovery process in a successful and smooth way. And sometimes they may not recover and lose their life post-operatively because of nutritional deficiencies even. Safety is another issue. Safe passage to bring patients to the hospital, to bring staff to the hospital, to bring resources and supplies to the hospital. And on the other hand, safe passage to take patients to other care centers is an issue. Next issue with safety is safety of the facilities themselves. Unfortunately, despite the fact that by international humanitarian law, all healthcare facilities, healthcare automobiles, and healthcare workers are supposed to be protected, we have seen that over the last few years, there has been a rise on attack on healthcare facilities and healthcare workers, to the point that WHO has actually raised the alarm on this issue multiple times now, and they have not seen any, unfortunately, consequences for these attacks on healthcare systems. Now, there is an intersection for policy here. As I mentioned, the international humanitarian law protects us, but this is the data I have pulled this morning from actually I'm sorry, the images have cut off. From the WHO's a tracker. We can visit the tracker together, but essentially 396 injuries have been reported in the last 5 months. This data is from January 1st. And it's been done in 13 countries and territories. That's where the reports are coming from. 165 have been attacks that impacted transport. 237 attacks were impacting the personnel, 45 the facility, and 102 was on the medical supplies. And with this other diagram that unfortunately is again cut off, what we see is that the type of attacks, the most common one involves heavy weapons. The next type is with obstruction, and then individual weapons and psychological violence and removal of the personnel from, facilities, which would be equivalent to getting arrested and so on. I'm going to ask a question to the audience. Do you know what is WHO's hashtag for us, for healthcare providers? Anyone want to put that in the chat? Okay, I'll share it. It's not a target. Not a target. Why would we need a hashtag that says we're not a target if we are not a target? We are a target. That's what it is, right? Unfortunately. So this is something that unfortunately we have the policy in place. It's legally binding, but we're not seeing an impact. And personally, I hope for the sake of all of us and all the healthcare providers and aid providers to regions of conflict that we see some change for this issue. So what are the organizations that you can advocate to or reach out to in areas of conflict and times of conflict? Surgical colleges are amongst the organizations that do at times like this provide care and aid. American College of Surgeons has at times through Operation Giving Back, which now is called ACS Hope, provided both instrumentation and deployment of surgeons. That has become less in the recent years, but they have shifted their focus to training workforce for regions of conflict. Royal Colleges of Surgeons of Ireland and England are similarly involved in those types of activities, and you can find resources through them. Non-governmental organizations like Medicine Sans Frontières or David Knott Foundation are also involved in both deployment and, in case of David Knott Foundation, training a workforce specific to conflict regions, because as much as basic surgical needs and healthcare needs are there in areas of conflict, there is another layer added of knowing how to manage patients who are severely injured in low resources of a conflict, as well as doing this safely, that needs to be added to our training. Most of us are not trained for this type of environments, and there's an extra training that would be very helpful. There are mission groups that form oftentimes, and something that I personally have witnessed is that when official and proper channels are overloaded and unable to manage the emergency volume that's coming through, a lot of mission groups form. Surgeons, anesthesiologists, and critical care specialists are very good at self-organizing, and when they form these groups, they oftentimes are able to navigate deployment through help and guidance and organization with the WHO Emergency Office, because entering the areas of conflict is not an easy or trivial thing. It has safety issues that we need to be concerned with, and also exiting will be an issue. The other problem is that we need to make sure that we coordinate efforts so that we don't duplicate and overwhelm the resources that are on the ground. So I have seen that that has been done both by physical deployment, and the other way that I have seen it done is also through telemedicine, specifically in, and I have a paper that's coming up in a few slides ahead. In terms of Gaza's aid and Ukraine's aid, telemedicine groups formed that had about each thousands of surgeons and critical care specialists that were providing consultation to the surgeons that were on the ground, because many of the hospitals had surgeons that were early career, maybe 2 years out of residency without trauma training. And what they would do, they would come back into those chats and post patient cases and ask for suggestions and approaches to treatment, and they would get consultation from surgeons that were across the globe. Or even nurses and ophthalmologists, any type of injury that could be possible, they would post in the chat. In terms of academic institutions themselves, you just heard from UGHE and what they are able to offer. At Baylor Center for Global Surgery, we have a program for trauma education that happens every Tuesday, and it's actually open to anyone that is interested in learning that skill set. This was initially developed for the surgeons and residents in Myanmar who are facing a conflict right now, and they have been prosecuted and under attack over the last few years because of the conditions in Myanmar if they wanted to provide care for patients. Because they have no access really to education and trauma, this course is developed, and it's every other Tuesday. And as I mentioned, I'm happy to share the link with anyone who is interested to register and join that class. In terms of advocacy opportunities, now that hopefully you got the lay of the land of who are the players and who you can ask for what in terms of funding, policy, and so on, what are the ways that you can advocate? One is through direct channels, contacting the organizations that I've mentioned so far. The other is through social media. And social media advocacy, it's important to unify forces with each other, have proper use of hashtags so that you can go viral and rise to the top of the content that is in each channel. You can publish op-eds in journals that are well read and are available to policymakers, etc. Research articles are quite critical because it is where you can present the data as it is, the medical, the human factor data in a way that you cannot potentially post just on social media. Because it is validated data, the bias in it is not going to be something that's going to be coming up and questioned. Hopefully it will be seen as pure evidence of what is happening on the ground. Now, it might be difficult to get these papers published, but it is important to see the value of them. And it can be used, this evidence, this research, it's critical to understand that it can be used in a multitude of ways. Other than going into a medical journal, that evidence can be used for evidence-based advocacy, for writing briefs, for writing one-pagers, for writing social media posts. It can also be used for further demonstrating in panels and presentations about what is happening on the ground. And in that sense, it is very valuable. Another value of these research articles that you should be aware of, which in normal times we don't think about it in the times of peace, is that data is directly evidence that can be used by international criminal courts for any proceedings that they may have. So there's quite a value to research data coming out of areas of conflict. Panels and presentations, as I mentioned, are key. However, they may be difficult to come by depending on the organizations that are setting up conferences and the willingness of organizations to put on these panels about areas of conflict. And of course, all of this can be used for news outlets as well. And there is a strong value and a strong voice always to hear from a surgeon, from a physician, from a healthcare provider on a news channel about an issue of conflict. Now, what are some of the challenges you may face? Conflicts are often politically polarized, and you may face resistance in any of the channels we talked about. On social media, you may face shadow banning if you're not familiar, but point out when what it means is that your posts that might have been regularly seen by hundreds of people or thousands of people, if it has certain keywords of, let's say, a certain region of the world or a certain keyword about like violence, may all of a sudden not get the same engagement as your other posts, as your regular posts. And that commonly is due to something that we call shadow banning. And no one is immune to shadow banning online. I have seen Dr. Tedros be shadow banned. So don't think that it's personal to you. It happens to everybody. It has to do with the algorithms of these social media networks and also what the polarization of the discussion that you are bringing to the social media is. The other issue that could happen to you and you should worry about or watch out for it and be careful with it, not so much worry about it, is targeted attacks and doxing. And that means you, for any type of advocacy, it doesn't even have to be for areas of conflicts, you may be targeted by people who oppose your views, and they may dox you, release your personal information online, where you practice, where you work, ask for your license to be revoked. It happens, unfortunately. We live in an era that online, behind unnamed profiles, a lot of people are very bold in attacking individuals and especially towards healthcare providers. So that's something that you need to think about. Depending on how polarized a topic is and depending on country of practice, you may even face loss of job and professional privileges for the political views that you hold and the support that you're providing for a conflict. This is not to make you scared, it is to make you aware so you can find ways around things. I had an opportunity to have a conversation with the head of emergency responses at WHO, and he said a quote that has stayed with me for now 2 years, which was, "You are a physician, you have a side in every conflict, and that side is the patient's bedside and nowhere else." So anytime I make a statement about a conflict, I try to bring that up so that everyone is reminded that it's not my personal opinion of who's right or wrong in that conflict. It's about the patients that are suffering that I'm trying to help. So how can you help? At every stage of our careers, we can help those who are suffering through a conflict, whether it is by advocacy, by education, providing educational resources and tools, as I mentioned before, by data collection. I told you the value of that data and how far it can go. You may not be in an active area of conflict. You may not have the ability to travel there, but most of us are trained to do research and process data, lend a hand in data processing, lend a hand not so much so that you get an authorship on a paper, lend a hand so that the data can be processed in the proper and ethical way and comes out in the right way. Because the people who are in the active area of conflict may not have the time to process that data. They may not have the time to deal with the journal and go back and forth. Maybe you can help them with that. And again, the focus should not be on you gaining an authorship. It should be on that data being presented in the right way. In terms of resource management, you can help by resource mobilization. Even if you are not in the area, if you are in the area, then you may have a better even understanding of the lay of the land and where the resources are coming in, where they're getting stored, where are the needs, what are the needs, and you can help manage that. And if you are able to travel and provide direct medical care, or if you are there, part of the community and able to provide direct medical care, that is another layer of opportunity to help with areas of conflict. At the end of the day, in my very humble opinion, support for areas of conflict is really in three aspects, main aspects of education, preparation, and support. And this is a continuum, education from before a conflict starts so that we have those resources and those individuals who are trained, preparing well for the times of conflict, and providing support not during only, but also after the conflict. We need to remember, we don't talk about this often enough, these conflicts, these traumatic events that our communities and our colleagues go through, whether they are local to that region or traveling, have a long-term effect, have a well-being and mental health effect, physical health effect that we should be addressing. We should support them, and we should be cautious of how that impacts our workforce and our colleagues over a long period of time, and openly talk more about the traumatic stresses that comes from being in those areas or being in contact with conflict in general. With that, I want to thank you for the opportunity to be here with you and have this discussion. I have information for contact for CMORG, which is a new collaborative that I've started, and of course, the Association of Academic Global Surgery for anyone who might be interested. I'm happy to answer any questions you may have.
If I may, I just want only one quick question. How can we approach the stakeholders? Sometimes we have advocacy campaigns or advocacy ideas, and we cannot reach out for those who have much power. So how can we do that?
So in terms of stakeholders within, first of all, don't ever underestimate a cold call and a cold email and finding contacts through there. The other factor is that within the global surgery community, there are organizations that have alliances with all the stakeholders. For example, the G4 Alliance is one of those organizations. Perhaps if you reach out to them and ask for some support, they will be able to, share your message of request for support or request for advocacy with their network of members and give you some support that way, because they have about 80 organizations that are members of them at this time. I have learned that also personal relationships that you form online, on Twitter and so on, can be helpful. At times of conflict, sometimes it feels very helpless. Even from afar, I can share an experience I had about a year ago where someone was stuck in an area of conflict and they needed a safe passage, and they were a healthcare worker. They just wanted a safe passage. And I remember that I knew someone online who was part of MSF. So I reached out to them, they reached out to their contacts in Red Cross, and we were able to loop back some information about where the safe passage is and how to get the safe passage for this person. So don't underestimate those human connections and contacts that you form online. They could go a long way.
Thank you very much. There is only the last question with Wissam because we're running out of time. She's asking about the organizations that we can contact typically for any advocacy campaigns, I guess. So she mentioned that can some organizations have a plan to resolve the problem, or we are going to have only, can they help with the full picture? I'm not sure that I have understood her question, but I think that's, you can find it in the chat also.
So depends on the organization's capabilities and resources, of course, right? Every organization has a different set of tools in their arsenal. Sometimes those organizations may be able to have other colleagues and partners in other organizations that they can actually bring together, resources together and help. It is hard to know from the get-go when you go to an organization if they are going to be able to resolve 90% or 100% of the issue. I see one last comment. Yes, so in high-intensity war zones such as Sudan and Gaza, surgeons are developing adaptive approaches to manage extreme emergency and critical cases under high pressure. Their methods born out of necessity in resource-limited environments often diverge from the conventional protocols. When foreign physicians arrive, they frequently find themselves immersed in unprecedented medical practices and informal mode of operation. How can these methods be ethically evaluated and safety and efficacy given? Yes, how can we know the safety and efficacy and ethics of these methodologies? So in methodology of war surgery, my experience and understanding of it is that as we looked at that consensus, the first stage is to save a life, right? And then you go higher acuity of having better access, better resources, and going more into saving function and form and so on, right? In terms of what I have seen with Gaza, for those telemedicine chats, the individuals that were invited to that chat were not just high-income country surgeons, it was surgeons who were experienced in war surgery. For example, one of the groups that I mentioned, David Knott Foundation, they are extensively experienced in this. MSF, extensively experienced in this. And also what we found is that I have seen that in areas of conflict, our colleagues who work in low resource settings have more knowledge on how to handle a war situation better because they are used to resource management and techniques that don't use laparoscopy, for example. And it's, more direct by hand techniques. So those are the individuals that seem to have more knowledge to offer. So for telemedicine approaches or even deployment, those individuals have a stronger sort of foothold in that. Validating these techniques and making sure that they are perfect is not possible because no two injuries are going to be exactly the same, right? So as long as the primary objective, immediately saving a life, and the secondary form, function, so on, comes after, I think that is the way that we look at success of these surgeries. It's not a normal time that we can standardize protocols, if that makes any sense. I hope that gives you an answer.
Yes, thank you so much, Dr. Kitayan, for this insightful presentation. Before going to the next presentation, I'd like to ask about how could we to catch or to gather opportunities to influence funding and system level support for surgical services during war and through advocacy per se.
That's a very good question. As I mentioned to you, there are two main resources for funding through the UN that comes through, but majority of the funds that I see coming in the areas of conflict and I'm watching is coming through philanthropic support. So really, it goes through the will of the NGOs and what they're able to raise funds. My experience has been that the fundraising is not the problem once you have the funds. Now, how do you, whether it's a disaster, natural disaster, or conflict, you raise the funds in a relatively short time, the issue becomes, now how do you make these funds into resources and deliver the resources to the right place? Because if you have no safe passage, if you you purchase devices, which I personally have faced this one in a natural disaster, we purchased crush injury sets, Stryker sets for orthopedic injury, and we were told not to deliver them because they would be sold on the street. Because unfortunately, the governing body of that region at that time was doing some corrupt activity. So I think that second portion becomes very difficult and tricky. And the best way I have been able to manage it, and again, my experience is more disaster than war, was through community themselves. When we reached out and said, we're running into this thing, we cannot bring the sets in, how can we get this to you? The community members themselves knew how to get that funding, that resource into the community and get it to places that needed to get to, rather than us intervening from outside. So I think this is where coalition building and collaboration with people who are in the community is far better than us from outside trying to figure out, or any outsider to figure out how to bring in funding and resources.
Yeah, actually, that makes sense. Thank you so much for the answering and for the very, very insightful presentation. We are happy that you join us today. So we need you still. We will present. Well, let me first introduce myself. I am Ilaf Abdrahim, and I am the Communication Advocacy Department Director at the SCSD. And we would like to present our role as a nonprofit organization in Sudan that mainly in research and advocacy during war. So that would be like a little break between the two panels. So Nazaria, you can start.
Thank you very much. I will just share my screen now.
Now, we can see your screen. Yes, yeah.
You can see it now. Okay, thank you very much. So first of all, thank you very much, everyone, for joining us tonight. Thank you for Dr. Madni also. I'm Nizar Ibrahim. I am a junior doctor and a master candidate in global surgery. I'm also serving as the research department deputy director in the SCSD and part of the advisory board in Jazeera Student Surgical Society. So we're going to talk a little bit about the Sudan surgical landscape, especially now in the conflict. We're going to highlight the SCSD efforts on global surgery in conflict now in Sudan. So first of all, it's very important to start mapping the surgical services and surgical infrastructures in Sudan before having any efforts on advocacy, for example. So we're using the data to advocate for change. So basically, based on research results, most of the all-aged population, more than 55% in Sudan, lives in areas greater than 30 minutes from the nearest hospital. So this is a problem of an access. So at least more than 55% of the Sudanese population, even before the conflict, was not able to come in to the hospital in emergency in the right time, especially that there is no good infrastructures in the ambulance or the roads, for example. So what we are doing in SCSD, we're trying to have like a big picture to start mapping this infrastructure and other important things. So we have started with in this term, we have started with 3 major projects in this conflict, starting with the trauma infrastructure within conflict. We have research for this specifically in the conflict-affected regions of Sudan in 5 states. We found that only 4.2% of the hospitals have adequate equipment and availability for some basic trauma needs, just like oxygen ventilators, blood products, CT and MRIs. Only 4.2%, and this is very, very low percentage. There's also chronic blood shortages. The triage protocols are not managed properly. There is a huge problem with the preparations for the mass casualties. We have only 20.8 of the participants in the study reported there was no preparedness at all, while only 8.3 felt fully prepared. You can imagine that only 8.3 of the surgical capacity that we have, medical officers, surgical residents, and surgeons, only 8.3 felt fully prepared. So this was shocking to us. That's why we continued with another research about the preparedness of mass casualties incidents during the armed conflict in Sudan. We found that half of the participants had received prior MCI training or mass casualties incidents training. So knowing that only we have 50% of training, that highlights a huge area for improvement. We also found out that there is up to 3,500 MCI cases monthly. So this is a very big number in the high volume hospitals that we have that we investigated. We also investigated the communication referral barriers among the mass casualty incidents. We found that there is a very big referral gap, especially that there is no much working hospital, especially in Khartoum previously and Darfur and Kordofan. 80% of the doctors reported there was lack of organized referral systems and effective referral during the MCI. So that brings us to the advocacy, but we're going to talk about the impact later. We will also, I also want to highlight our other study about the WASH infrastructure and its impact on the surgical site infections in conflict zones. So the data showed that there is a clear distinction between the hospitals in conflict zones and those in non-conflict areas in Sudan regarding the SSI cases and the WASH infrastructure. It was basically better in some areas in Khartoum before the conflict, but after the conflict arose, there was very big problems with electricity, with clean water, and other stuff. That causes a very high SSI counts in hospitals in Khartoum in comparison with other hospitals in Atbara and Kassala, for example. So one hospital, even a Turkey hospital, they had no inpatient available. So all patients who came with who came to the hospital, they have their emergency surgeries, then they are discharged immediately because no one can stay in the hospital. So they managed to do like a clinic for the SSI. So they have more than 70 surgical site infections coming every month, only for the follow-up in this clinic. So what we did with this research. So from research to impact, we are building a comprehensive online training program focusing on the mass casualties response to train the junior and middle level doctors so they can provide better care or better surgical care for their patients, especially in the conflict zones. We're also drafting a national surgical care protocol especially for the forced detention survivors, those who have survived the detention. We're having, in collaboration with the Federal Ministry of Health, we're forming a working group so we can work in this issue. Now we are maybe in the second phase of this protocol drafting. We also have 7 monthly journal clubs advocating for evidence-based change. We are highlighting all the papers that we can find that was published during the Sudan conflict, so we can, and we are also hosting and having the stakeholders or the effective personnel in each specific area, so we can have some sort of help. We hosted the Sudanese Medical Specialization Board director. We have discussed many things about the training of the Sudanese doctors now during the conflict, especially that everyone is fleeing the country and there is no active training nowadays. So I think that's for the research. We're going to show you some video, a YouTube video about the advocacy efforts that we have done. Just give me a second so I can share the video with you.
Well, neither we lost your screen if you're sharing.
Yes, just give me 1 second.
Okay. So I can tell you more about the upcoming video. It is like one of our advocacy methods that we adopt, storytelling, and to reflect a real patient, displaced patient experience, and their hinder of productivity and suffering because she's not gotten access to surgical care after her displacement. So it is like a supportive to the data we actually have. Yes.
الرحمن الرحيم. مي يونس، سكن الثلاث القبة. لدي بنت وولد، ربة منزل الآن، ربة منزل. كنت شغالة أستاذة 3 سنة، وقفت الشغل، قعدت في البيت. طبعا بعاني من البواسير لي 20 سنة. مشيت الدكتور اتحددت لي عملية، وبالنسبة لظروف الحرب دي يعني ما قدرت تاني أواصل إني أرجع تاني. يلا طبعا الحرب دي لما قامت يعني كنت بتعب شديد، يعني ثلاثة شهور، طبعا قعدنا 4 شهور. لما كنت بتعب يعني بحاول اني مثلا امشي الدكتور، ما في طريقة نزول عشان يمشي الدكتور، يعني كنت بتعب شديد عشان اوصل اني امشي المستشفى الحتة، وما في حتى مستشفى يعني نزول يمشي لها قريب، الا يكون مستشفيات بعيدة كده. والله بعد ذاك هو طبعا ما في يعني علاج، ما في حاولنا نطلع عشان الواحد يمشي يشوف حتة علاج ونطلع لبر الأمان يعني. الطريق أخذ يوم كامل، يعني إحنا كنا قاعدين يعني قاعدة واحدة في الطريق، يعني كانت القعدة طويلة، يعني القعدة كانت طويلة والواحد يعني تعب من القعدة، لأنه الجو مساك شديد، الإمساك هو تعب الواحد في المسير. طبعا أبونا خليناه في الخرطوم، ويعني أنا قاعدين هنا يعني الظروف المادية يعني صعبة جدا. كنت ماشية الدكتور عشان أمشي أتعالج، ما في طريقة أمشي إني أتعالج، الظروف يعني مادية، وكنت يعني بتعب، يعني أخذ لي مثلا أسبوع كويسة وأسبوع كنت تعبان شديد، يعني كل فترة بكون تعبانة، يعني ما قادرة أشتغل ولا قادرة عشان يعني أمشي أعمل حاجة. ما لقيت طريقة إني أنا طريقة علاج هنا، فكرت إني أرجع الخرطوم.
Yes. Thank you so much, Zed. So let us get back to the presentation. So actually, like, my story is very heartbreaking, and it's not rare. Like, it is the reality of many Sudanese families during the war, and it is one of million of people that cannot access to surgery. Admits that her surgery is not that complicated. It's very simple, and it is usually affordable. So if you want to watch the video again, you can just scan the QR code below and enjoy it again. Thank you so much. So next, please. So as we said, numbers talking always. Like in one of the displaced camp in West Darfur, they found that they examined 1,400 people, and they found that when in poor people living with untreated surgical conditions vary from trauma, burn, and emergency childbirth. Next. So at the other side, like actually doing surgery can benefit the the healthcare system and benefit the economic status of the country, as we just indicated in many research, and one of them is in South Sudan. There are also a number of the return on investment, and so many are. Next. So what we are trying to do, or what we are trying to advocate for, actually the international there's international recommendation, and the Lancet Commission on Global Surgery said that every country needs to have the national surgical obstetric anesthesia plan to strengthen the surgical system, especially during a conflict or infrastructure collapse. So countries all around the world and around Africa are adopting this plan, and Sudan must not be left behind. So actually, the focus area of the National Surgical Obstetric Plan, next, Nadar, are focusing on building infrastructure and train workforce and improve the service delivery and financing, and also strengthen the information system. So this this plan is designed to fix a weak link in our health system. So actually adopting NSOB is one of our key areas of advocacy in the SCSD. So next, how we are doing that? Actually adopting and implementing the National Surgical Plan start with government ownership, and then they do the baseline assessment and stakeholder engagement and so on. But really we like started with the stakeholder engagement and start to prepare and write a proposal for baseline assessment to create a momentum for the Minister of Health to adopt and to convince them to adopt such a plan. Next. So basically we are, as I said, we are doing the data collection for the baseline assessment. We are starting doing this, and we organized a local and a national or even regional conferences. We're preparing to do this also, and meeting like this forum as well, and produce a real life storytelling documentaries like Stories of May and so many. And also we are showcase our the importance of the National Surgical Plan in the social media, and you are trying to do or to include the mass media, like the local mass media, the radio and television. Next. So beside the policy advocacy, we are advocating for many surgical issues that are facing our people. It's not all about trauma or childbirth or like war-related injuries. Actually, we are tackling other surgical issues. For example, cancer care in Sudan during war have been like neglected, and after the destroy of the key facilities at Khartoum and people displacement, they actually suffering from lack of access to essential medical equipment and medical care and surgical oncology services. So we conduct many campaigns regarding cancer on social media. Next. Like we start by advocating for the prostate cancer care, and we actually meet the reproductive cancer unit in the Ministry of Health, and we had a lot of talks, and also we target our population, the community, through social media. And we also talked about our conducted campaign in the breast cancer as well as colorectal cancer. As if you, in your point, being following our social media platforms. Next. Other than cancer, we address the burden of the diabetic septic food, and we like have a lot of meeting with the stakeholders, and one of the centers managers in the diabetic septic food. And we also conduct an awareness campaign regarding the preventive method of diabetic septic food and how and when you can seek medical care. Next. Also, coming back to the policy advocacy, we advocate for we conduct many panels regarding the National Surgical Obstetric Plan, and have a webinar about the global surgery in general as a new concept in Sudan and the role of Sudan in the global surgery. The last thing, and maybe it is not that aligned with the situation, we had advocacy in empowering the women in surgery. Like Dr. Katayani mentioned that in the past or in the previous surgery was all for men, and men should go to war to be a surgeon. So we actually had a panel and had many female surgeons, Sudanese female surgeons, who share their stories and give us an advice and a roadmap on how to be a good surgeon as a woman and facing all the odds. So I think that's all. Yes. Thank you so much for listening. And this come to conclude my presentation on the CSD role to improve and support surgical care in Sudan. Thank you so much. The mic back to you, Nader.
Thank you very much, Khilaf. I think we will proceed now with the next panel. Dr. Ahmed Walid, please open your camera and mic and go ahead.
Thank you very much, Dr. Nazar and Dr. Khilaf, for this insightful presentation. And thank you also for highlighting to all of us the presence of this good work in advocating and in supporting the global surgery in Sudan. Hello, everyone. It's an absolute pleasure to welcome you all again to our next sessions. We will be diving into the incredibly important and deeply inspiring field of humanitarian surgery, a cornerstone of global health equity and a vital branch of global surgery. Firstly, I would like to introduce myself. My name is Ahmed Walid. I'm a fresh graduate from Faculty of Medicine, University of Jazeera in Sudan. And I have previously worked as the president of Jazeera Student Surgical Society, JES. And now I will be honored to be your moderator for this session. Humanitarian surgery is more than just operating in crisis zones or responding to disasters. It represents a commitment, moral, and professional responsibility to ensure that safe, timely, and affordable surgical care reaches those living in the most vulnerable and underserved regions. From conflict zones to refugee camps, from natural disaster sites and to impoverished rural hospitals. This field brings the skills, the compassion, and the resilience like a few other fields. At the intersection of global health, ethics, and surgical innovation, humanitarian surgery is the global surgery in action. It also reminds us that the surgery is not a luxury, it's a human right. Today, we have the privilege of hearing from two outstanding leaders in this field. Their experiences, insights, and stories will not only inform, but inspire us to think more deeply about our role in building a more equitable world through surgery. To begin our journey, I am thrilled to welcome Dr. Michael Mawandry, a trauma and humanitarian surgeon, global surgery advocate, and medical educator based in Arusha, Tanzania. Dr. Mawandry brings over 15 years of experience in trauma care and humanitarian surgery across Africa and Middle East. His work with the International Committee of Red Cross on managing weapon wounded trauma, his leadership in developing surgical protocols make him a true pioneer in this field. Let's give a warm welcome to Dr. Michael Mawandry. Dr. Mawandry, the mic is yours.
Hello, everyone. Can you hear me?
Yes, your voice clear.
Okay, thank you very much, Dr. Walid, and thank you, Nizar, and everyone here. And thanks for the kind words as well. So I think I have a few minutes to talk about humanitarian surgery and share my experience with the ICRC, where I've been working with for a couple of years now, almost 10 years. Nizar, can you project my slides? I think, yeah.
Yes.
Take it from there.
Yes.
Okay, good. So yeah, I think as many speakers have alluded before me, yeah, it's an important part of the global surgery, and even though it's often in the conflicts and the emergence crisis, but then it means to take on from the emergence to to a kind of development situation where things are calm. But then the challenge is how to transition that, and as well as how to prepare before the crisis happens. If you go to the next slides, please. Yeah, so the impact of the humanitarian surgery, I mean, whenever there's a conflict, the pictures on the TV, on the news is spectacular, and it's really touching, and that everyone sees it as it offers the access to the healthcare for the majority, for the people who are desperate in the conflicts. So obviously, yes, it gives access, and in many times those people may not have any other means of accessing surgical care if it's not for the humanitarian organizations. I mean, picture the work of the Red Cross or the MSF or other major organizations whenever there is conflicts, and you can see there the impact of the humanitarian organizations and the humanitarian surgery. But then there are other obscured impacts which I wanted to bring to your attention today. So apart from the access to surgical care, as I said, often during the at the crisis, the population may not have any other means of accessing surgery, at least to not entirely comprehensive access, but to some extent, yes, humanitarian organization offers some access. But then there's other impact which I wanted to highlight, as I said. I mean, most of the time, humanitarian organizations operates using certain protocols. They may differ from a surgical practice before the conflicts. Okay, so those protocols often they are very effective. Okay, and they can be rolled out using a very low cost. So, and unfortunately, they are not well adapted in the medical schools, in the universities, and these are kind of things which you encounter during practice. So I think if those could be infused to our curriculum, or if those could be brought about to the doctors through short training, then that's one of the impact which it's kind of obscured, and I wanted to highlight that. And they will see some of these as we go along. And with that, I think it offers the opportunity to forge a resilient and sustainable system, kind of trauma system. The approaches could be, what Dr. Nizar mentioned about the mass casualty preparedness. You can imagine, because at least in many surgical training, it's not something which people really dwells on. But when there's a conflict, then you need to have some kind of protocols. People need to rehearse, or the emergency system need to spring back on that. And yeah, so that's one of the approach which can make a change. There are other things like task shifting. Often there is deficiencies of personnel and skills, and certain skills with very high impact need to be taught to whoever is there. And that's where the role of task shifting comes. Task shifting means, okay, you are not obstetrician or gynecologist, but you're a medical officer who can learn to perform a delivery or straightforward cesarean section or do a good assessment. So you shift that task from a consultant to experienced physician or a general doctor, to offer the possible best service at the moment. So that's task shifting, and the list goes on and on. I'll give you an example. When we had a mass casualty some time back, and then we had cleaners, they never been involved in every clinical care, but then you could show them how to sweep the floor, how to bring in some suction machine, how to carry patients, and they could really perform well and help out, even though it's not their roles, but it's a kind of low risk activities which they could be taught in a short time. So that's a good example of task shifting. And yeah, that can be adapted to other areas as well. The training is important. And training, retraining, some of the skills are very practical. They are not well used. Some of the protocols could be very new to the people around. So training and retraining and how to make sure that the training is effective, that's important. And then the audits, if you don't see your outcomes, if you don't follow your outcomes, you're not going to improve, you won't know what you're doing. So even in the conflict, you still need to look at your outcomes and decide where to improve. The private-public partnership, the financing and enabling the services, this is one of the critical areas. And I think I'll talk about it more in the next slides. Yeah, next slide, please. So yeah, it is challenging in the conflict area. Yes, we heard about usually there is upsurge of almost everything. Even the diabetic will be worsening, diabetic foot will be rampant. It's going to be cancer and infection and everything, medical conditions. But then the surgical related conditions resulted from weapons and conflict itself. Often the presentations are very late. They don't come fresh. I've tried to put these two pictures here. There's the war surgery manual is kind of it's an important reference for most of the humanitarian surgeons. It's written by our senior colleagues in the ICRC, in the Red Cross, and it's been around for some time. So yeah, most of the protocols are in here. Please, this book is online. I would refer to any medical personnel, not necessarily doctors, anyone who has interest. Please go through it and see the approaches. They little bit differ from what we do in our usual surgical practices. And then there's another insight, small. There's another two pictures here. One on the far left. This is a soap. It's a simulation. It's a simulation of the gunshot. Okay, and you can see. I'm not sure if it's very clear, but you can see there's like there's a trajectory, yes, and it tapers down. So on the far hand, it's huge, and then on the other side, it's really small, and then you see like a metallic fragment. So it's a bullet there, or a fragment, whatever it is. So this is actually the mechanism of the gunshot wound, or a fragment or shrapnel from the blast. So the movements of the trajectory, usually it spins and then it spins and then it goes, it rolls and it spins. And because of the energy dissipates, and because of the consistency of the soft tissue, often the entry is small, and then in the middle of the tissue, okay, the wound becomes bigger, the destruction is much bigger, and then towards the end, it becomes small again. So when a patient presents, and I've tried to show the patient here on the other side, you can see the entry and the exit. So when they present, often you would see the surfaces, not necessarily that it's going to be huge wounds, in, out, entry and exit. Sometimes it's a very small entry and quite, relatively small exit, but then you don't see the inside. Okay, and this is important, pathophysiological differences between these kind of wounds and the kind of wounds you see in civilian population, because then the approach make a big difference in the patient outcome as well. So these kind of injuries, to be able to effectively manage this, you need to follow certain protocols. In the Red Cross, and I think MSF and many other surgical organizations, what we do is we stage this kind of injuries. First of all, you do a good debridement, and then you're not going to close it. And then you come back maybe for 5 days. And then if you have done a good debridement, then after 5 days, then you can be able to close it. And then now, when you close it, you always have to think about the outcomes and think about the functions. There's a lot of reconstructive needs here. You can see there is a destruction from the skin, soft tissue, tendons, muscles, nerves, blood vessels, and skeletal structures. So ideally, you would need all those consultants to come and work in this one patient. So you need a general surgeon, a plastic surgeon, a vascular surgeons, and maybe an orthopedic surgeon, and plus other helps from physiotherapy, nursing care, psychosocial, anesthetist. So usually in a conflict setting, you don't have all these people. You only have, a handful of people, and then you don't have a lot of resources to deal with this. And this is where I want to insist. This actually signifies the needs and the burden of a trauma surgery in the war zone, because then you need to have all these skills. You need to be competent in most of these areas, and you need to know the protocols. And this is not something you you learn in a medical school most of the time, even in a surgical training, most of the time they don't cover all this. But then I think where we are now, we need to stress this and bring them up. And this is where the role of the training and retraining in some of the protocols is important. Most of these protocols are in this book. So yes, if I think that's one of the area. And so the best practice will be having skills adequate enough to address the clinical aspects, to think about the outcomes, to think about the functions, because this patient at the end of the day is not just to close these wounds, but then you want them to walk, okay? So probably some of the things, like I think I heard from other presenters, if you want to do internal fixation in this leg, it's not going to work because it's going to be infected. And maybe Rizarov or X-Fix will give you a very good outcome here. Maybe a POP backslab for some time before you can do any reconstruction can give you a very good outcome here. So you need all these skills, okay? Now, unfortunately, in conflict settings, at least in immediate conflict settings, not many people will have all these skills, you know, among just few clinicians. Often you need multiple specialties, and you don't have a luxury to that. And then also the equipment. Not many people be familiar with a really effective equipment for this kind of injuries. And at the end of the day, it's quite challenging. But then I think with the training, very specific training, focused on patient epidemiology. And this is important because everything will depend on kind of patients who comes in a particular area at that time, okay? If you're working in a trauma center somewhere in New York or in London or somewhere in a big city, and then all of a sudden you're in the middle of nowhere and you have these patients, probably you won't know what to do with it. And that's where actually these short trainings and focus on the patient epidemiology, looking at the outcomes, looking at the protocols, this is absolutely important to improve and to offer the best practices. Now, back in the days, myself and a couple of colleagues from South Africa, where I trained for my PhD, we devised something called Afrocentric trauma system. Trauma system is quite a common approach. It's an effective surgical system where a patient can be comprehensively managed through stages. You can start with lower level. First of all, you have a triaging system, and then you have a transport system. And then you have, you know, several hospital layers from the lower level to the highest, where is a teaching hospital. And then you have protocols. So usually patients will be transported, divided, and managed in these level of hospitals. It can be equivalent in most of the low middle income countries and in Africa, where I've seen, it can be equivalent to district hospital, rural primary health center, and then district hospital, and then provincial hospital, and then maybe referral hospital. So that kind of designation, but then there has to be some leadership, okay? There has to be some protocols. Now, the way you can devise this in Africa or in low middle income countries is different from the way it works in high income countries. Now, this form of system, if it's been practiced on before the conflicts, it can sustain the healthcare services even after the conflicts. Okay, the most important thing here is the protocol and the competence among the whole, you know, medical, surgical, healthcare profession population. Okay, so, and it's also another area where to train, and together all these can actually help to form the best practices around. Now, the trauma system has to have a financing mechanism, and this is where maybe it's going to be my next talk, but then probably this is the most important driving force, and I'll mention why I'm saying this. Now, if you look at these slides, we just covered the skills, which are usually very broad based, and then we spoke about the little bit of leadership and the system, okay, and the protocols. So if you put all this together and you couple them with this training, probably you're going to achieve some best practices, even in the challenging conditions. Okay, next slide, please. So remember my example of the simulation on the SOP, how the bullet traverses on the soft tissue. And then I showed you that wound, it's a limb injury. And I'll look at this one. So probably this is 80% of all the cases, acute cases in the conflict zone. Okay. And so most of them would be on the limbs, either lower limbs or upper limbs. Few of them, maybe 15%, will be on the torso, chest, or abdomen. And then most of the chest injuries will be managed by just chest drain. Few will need thoracotomy. And most of the 15% of the abdominal wounds will need some form of laparotomy, either staged or not staged. But then so the protocols differs. Okay, if you close that wound which I showed in the previous slide directly, you get something like this. And this gives you a joy only for a day or two. After that, then you have a fulminant infection, and which cannot even be salvageable, which cannot even save this limb. So the protocol here would be very different from what we do in the civilian situation. This wound will stay open, and maybe it will, require anatomical dissection to make sure that you have identified nerves, tendons, you have sorted out the skeletal injuries, and if there's a vascular repair as well, it's been repaired. So it needs a lot of skills, and often you don't have a multidisciplinary team to deal with all those. Okay, and that's where the training now can come and bridge the gap and try to impart the skills which are really important in conflict setting. And again, this is the difference between what is done in the high income countries and what is done in what can be effective in a conflict zones. Okay, so yeah, I've tried to say here, you have to control the infection, and that's a meticulous surgical technique, debridement, okay, sepsis control, and then secondary wound closure, which can be by directly suture, or it can be various stages of reconstruction. All right. And then stage surgery, as I say, you cannot close this wound directly. You have to, first debride, take time, and then come back and see how you're doing. You may need to go back and do another debridement. You may need to do a lot of washout. You may need to use some antiseptics, which are very effective. I like vinegar, dilute vinegar. There are many others like a Dakin solution. They can be really cheap, but then you need to have that in mind, like they're effective. And then orthoplastic approaches. In conflict settings, most of the injuries are limbs. So doctors, not necessarily only surgeons, doctors, even general surgeons, need to have some conversance on some degree of plastic, some degree of reconstructive skills. And so if you combine the needs, which are usually orthopedic, debridement, fixation, and then wound closure, then there's a new discipline called orthoplastic, and it's quite useful. It may not be very common among many doctors, but then according to the needs, these skills are important and they should be taught. And then the other thing is functional optimization. Yes, if you stop the infection, if you identify structures, tendons, nerves, you can always come back and do a repair and ensure that you optimize the function. The infection control is the most important here, because then if you can't stop the infection, then you're going to get gangrene or osteomyelitis, and then, wow, it's just wasted opportunity. So yes, function optimization starts with infection control, and then have an immense knowledge of anatomy, okay, respecting the structures and tissues. Yeah, but yeah, so these are very important skills. I can appreciate how difficult it is to attain all this, but yes, they would help to make a resilient health system. And I think it's important to impart to as many doctors as possible, especially in a situation where there's conflicts. Okay, next slide, please. Okay, so planning and executing effective services. When you have this patient who comes with a gunshot abdomen, or let's say a patient with polytrauma, blast injury, with injuries almost everywhere from limbs to the chest, abdomen, and then this patient is there, and yeah, he's a young patient, so he's somehow still stable, he's holding on, is not it doesn't show like severe failures. But then you have this patient, are you gonna spend a lot of time trying to chase the lab, getting the CT scan, getting the electrolytes while the patient is bleeding? Or what effective test you need to go in there and save these patients? Okay, so in conflict setting, the choices of the resources is very important. I've shown a few pictures here. So the red small gadget, this is called HemoCube. I'm not sure if many of you have seen it. We use these often in the Red Cross, in the ICRC. So this will give you a very good PCV or hemoglobin level. Okay, somebody comes who needs a quick fix, you can do a point of care. So if you have ultrasound, you have HemoCube, you have other small labs point of care, you can go in there and help the patient. Vis-a-vis, if you now want to send the patient to the tertiary hospital for the investigation, probably going to lose it all. And then the other picture here on the left to that, it's the abdomen. It's an open. It's a method of leaving open the abdomen. We call it a temporary abdominal closure. You can use a VAC, and you can see a negative pressure wound therapy here. Okay, then that means if somebody comes with severe abdominal sepsis, you can't close that abdomen because probably there is a compartment syndrome, intra-abdominal hypertension, and then you can't close that. Then you can leave the abdomen open. So you can put a sandwich gauze and then put a foam on top of it and tack it to the VAC, and then you achieve a very good modern temporary abdominal closure. You can come back after 48 or 72 hours, open the abdomen, go in there for second look, and try to fix whatever needs to be fixed. It gives you more. Okay, it's less. It's going to be less than 1 hour because you have very compromised hemodynamic situation of this patient. So you don't want you want to spend as less time as possible. Go back to the high dependence unit or ICU and stabilize this patient. And vis-a-vis spending 3 hours on the table and then you just get the triad of death. No, you don't want to do that. So yes, leaving the abdomen open, I think is a big deal. Okay, but then you don't need all these expensive and maybe modern equipment. Probably you don't have electricity. You can't get all these supplies. Can you use what you used to call a Bogota bag? Yes, of course. Why not? And it works perfectly well as well. Okay. So I wanted to say, what you choose to invest on, what you choose to train on and familiarize your team with, it make a difference, and it can really help you to optimize the situation. Now, the other one is the POP, and it gives you more compared to internal fixation or invasive orthopedic approaches, especially in acute situation. So with the POP, you can cut a window, cut a window and really take good care of this wound, plus fractures and everything. You can do a back slab, then you go back and open in a couple of days, okay? And often remember the limb is swollen as well, so you can't do a total circular cast, but you can do a back slab. There's another technique, we call it bridge POP. You can actually tackle the metal bars on both sides so that it just stabilizes, and then you can really get good opportunity to care for the wounds. And then after acute phase, 4 or 5 days, come back, now you can next phase. And everything is settled in a couple of weeks, you can now even convert that to internal fixation. Okay, that works. It's stage surgeries, okay? It's not very common in a civilian situation because you don't want to waste that time, but in a conflict setting, this is important. Now, how to do that? You need to train people. Okay, that was my point. I wanted to say that. Now, there's a machine here. It's called a Grostovant. If you've been to the most of the field theaters where MSF or ICRC works, you'll definitely see this. It looks very old. Looks really like a really low, old kind of thing, but it's not. It's a newer machine actually. So down here it has this is an anesthesia machine. It operates by low pressure. It's a low pressure system. So there's a concentrator here. Can you see this? So it actually uses an oxygen concentrator to deliver oxygen to the patient. So you don't need to have an oxygen cylinder. And then it has a battery in the back. So actually it can run even for 6 hours without any electricity. And then it's quite it's a durable thing. Well, I'm not trying to advertise for Grostovant or anything else, but I think when you choose what to invest on in a conflict setting, you really have to know what you're choosing, because then you can put a system which is too complicated. You won't have any oxygen. It doesn't mean that you don't have to operate at all. You don't have to do intubation. So if you choose well, okay, then you get more. Other things like point of care, ultrasound point of care, or mobile X-ray unit, or I don't know, HemoQ, and other techniques like peritoneal lavage instead of CT scan for abdominal wounds. All those, yes, they are surgical techniques. They're different from what we learn in a civilian situation, but they make a difference. Next slide, please. Yeah, so you need everyone. We have a so structure like SOP. I think one of the presenters talked about surgical obstetric anesthesia planning, SOP, which is it's one of the protocol for global surgery. We have a mobile surgical team in the Red Cross. And what the mobile surgical team means is you have an anesthetist, you have a surgeon, you have important peri-op nurses, you have physiotherapists, and it's a team of 4 or 5 people who can perform literally everything. Yeah, so that's kind of a collaboration. And then the way you approach things, you can't do it on your own. So you have to train people to work together. And this is one of the challenging situations, but yes, it gives you more. A couple of years back, we started using mobile phones to communicate. So I was in one of the hospitals I was working with, we called it GPS, because initially it was for GPs. So it's kind of secured system where you just text each other about patients, we share photos, and we try to make sure like whatever is done in the hospital, rounds and everything are posted there. Very effective. So in Cape Town, where I spent some time in Stellenbosch, they have a VULA system. It's a secured medical chat and referral. So the trauma director in Tygerberg or in UCT sees all the trauma admission overnight on the phone. There have to be a communication, okay? Make it effective. So this is important. But my point here is collaboration is important, interdisciplinary collaboration. You have to learn to work together. You have to learn to understand what everyone does. that give us a proof. Okay. I think then I'm going to go to my last slide. Yes. So data is important. You keep data, you track what you're doing, you improve. Okay. Trauma registry. Okay. And yeah, that's the whole sense. I think I'll stop here. I wasn't taking time. Probably I'm a bit short of time. I see Dr. Walid is here. And then I'll take some questions and clarifications.
Okay, thank you very much, Dr. Moandri, for this powerful, informative, and also insightful presentation. Our next session will be with Dr. Mr. Adam. Now I'm going to shift the mic for Dr. Abdelhamid. He will be the moderator for the next session. Dr. Abdelhamid, can you hear us?
Yes, I can hear you. Can you hear me clearly?
Yeah. Yes, clearly. You can start now.
Okay. Hello, everyone, again. And thank you, Dr. Michael, for your insightful remarks. They are truly appreciated. So, let me first introduce myself. I am Abdelhamid Abdessalam, a medical intern at Al Iman General Hospital and a graduate, Faculty of Medicine, University of Jazeera. We previously served as a deputy treasurer at the Jazeera Students Surgical Society 2020-2021 term, and I'm really honored to be moderating this panel today as a part of the second African Forum of Global Surgery. So, as we gather today to discuss the humanitarian surgery in conflict, it's impossible to overlook the urgent evolving crisis now in Sudan. Since the outbreak of conflict in April 2023, the humanitarian situation has deteriorated dramatically. Over 9 million people are now displaced, with nearly 7 million internally displaced within Sudan, and more than 2 million having fled to the neighboring countries. This represents one of the largest displacement crises in the world today. The health system in Sudan is under immense strain. According to the World Health Organization, over 70% of health facilities in conflict-affected states are either non-functional or only partially operational. These have left millions without access to essential healthcare, including emergency and surgical services. The surgical situation in particular is dire. Hospitals have been targeted, medical staff attacked, and supply chains for essential medicine and equipment disturbed. Basic surgical care, such as trauma surgery, cesarean sections, and wound management, is critically needed, but often unavailable. In many areas, patients must travel long distance, like my stories before, or should wait for days to access life-saving procedures. The shortage of surgeons, anesthesiologists, and operating theater capacity further exacerbate the crisis. In this context, humanitarian surgery is not merely a medical intervention, it's a lifeline. It's about restoring dignity, saving lives, and offering hope in the face of unimaginable suffering. The challenges are immense, but so is the resilience of our Sudanese people and the dedication of medical teams working tirelessly under these conditions. So tonight we are honored to have with us Mr. Adam Mohammed Ibrahim, a surgeon whose experiences embody this very spirit. Mr. Adam is a consultant in general surgery at Wed Medani Teaching Hospital, serving as an assistant professor of general surgery in the Faculty of Medicine, University of Jazeera. During the height of the conflict in Jazeera, he worked tirelessly in the humanitarian surgery at Wed Medani Teaching Hospital, providing critical surgical care at the time when it was needed most. His first-hand account for working under fire with limited resources and overwhelming need offer us not only a window into the reality of the humanitarian surgery in Sudan, but also a powerful example of courage and commitment. Please join me in welcoming Mr. Adam, who will now share his insights and experiences with us. Mr. Adam, the mic is yours.
Mr. Adam, if you can hear us, you can open the mic.
Hello?
Yes, we can hear you, Mr. Adam. So your voice is a little bit low.
Hello?
Hello, Mr. Adam? Yes, we can hear you. If you can just a little bit raise up your voice, we'll be very thankful. Yes, we can hear you, Mr. Adam, but if you could raise your voice a little bit, that will be better.
Hello, everyone. Hello?
Hello, Mr. Adam. Yes, now we hear you clearly.
Great, everyone. I'm I'm very thankful for this meeting.
Mr. Adam?
صوت واطي يا مستر، ما قادرين نسمعك. مستر ممكن تجرب تشيل السماعات، maybe الفويس يكون clear.
السلام عليكم.
وعليكم السلام، صوت واضح جدا، تفضل دكتور.
طيب. Thank you for this inviting for this forum for humanitarian in surgery case in Sudan. I appreciate for everyone. Can we start?
Yes, I will share the presentation. Just give me a second. Please go ahead, Mr. Adam.
The impact of armed conflict or health system in devastating, particularly in fragile states like Sudan. As you know, we have fragile health system, and the war come to us, and it became very bad. Humanitarian surgery become an urgent line for civilian caught in the crossfire. This presentation aims to explore the crucial role of humanitarian surgeons in Sudan's outgoing conflict, highlight the extent of the humanitarian
cross crisis using WHO data and examine the response gaps and offer recommendations for post-conflict surgical care. Firstly, immunization need in Sudan, data from WHO, Dr. Ahmed said, there is a million of people become homeless or refugee. Sudan has been engulfed in one of the world's most reported and devastating humanitarian crisis since the outbreak of war between Sudan Armed Forces and Rapid Support Forces in April 2023. According to WHO and COHA, for the coordination of humanitarian affairs as of early 2024. Over 15,000 civilians have died to direct violence, including gunfire and explosions and airstrikes. And also, more than 25 million people are in the urgent need for humanitarian aid, including 3.1 million children under 5 years at risk of acute malnutrition. Health infrastructure has collapsed in large part of the country. Out of 1,600 hospitals, only about 20 to 30% of hospitals, particularly, are partially functional, and fewer than 10% can perform surgical operations. I'm from Madani, as you know, and Madani has been, after 1 year of the war beginning, it becomes under the RSF, and we suffer a lot from the looting and destruction of the infrastructure of all the life of our life in Madani. So also there is 4.5 million people have fled their homes, as you know, leading to overcrowding in refugee camps with minimal health services. These numbers reveal spread need for trauma care, emergency surgery, and long-term rehabilitation, especially in war zones like Khartoum, Darfur, Jazeera, and now Kordofan and other states. We talk about the role of surgeons in war care injuries. Surgeons are at the forefront of the humanitarian medical responses in Sudan. Next. Operating under dangerous and resource-limited conditions. In Madani, we suffer from there is no electricity, no internet, and there is no even water for drinking. And they represent the black backbone of emergency and post-trauma care and key responsibility include emergency surgery for trauma victims. The surgeons in war, they do emergency surgery for trauma victims. Hello?
Yes, we can hear you, Doctor.
Oh. Sorry. Sorry. Then the surgeons also managing both surgical complications like poor hygiene, there is no electricity, and limited antibiotics. Zoonotic infections are common. Surgeons must often manage chronic osteomyelitis and infected wounds and multiple division surgeries in remote clinics. In Medani Teaching Hospital, we firstly supported by MSF. After 3 months, they left, and we shoulder the responsibility with our staff, and we work under a very bad situations. We threatened by armed soldiers every day and time, and there is very limited drugs. There is no even, as example, there is no insulin for the diabetic patients. There is very lack of every type of drugs. Also, the surgeons should train the local health workers, and we use, with Medani Teaching Hospital to, I myself, the only one surgeon in Wad Medani, all the time of for one year. I have 3 house officers and 1 registrar came to us at the last 3 months. And these 3 house officers act with me as outpatient doctors and assist me in the surgery. Due to specialized doctors, humanitarian surgery play a key role in training general practitioners, clinical officers, and even nurses to perform minor surgical procedures or assist in operations. And we we aim to, or we train the nursing to do surgical department for the patient with ESF or infected wounds because of the lack of doctors. Also, the surgeons should do should practice psychological resilience and focus. Many surgeons face psychological trauma themselves, working under constant threat of bombing or militia attack. This is what we have every day and night in Wad Medani for 1 year. 1 year. Syrians also become advocates, raising awareness globally and coordinating with non-governmental organizations and health clusters for resources and policy support. I also talk about the bridging the gap during crisis, challenging and solutions. When the guns fall silent, Sudan's surgical care system must be rebuilt stronger and more resilient. Here are key recommendations for future humanization, surgical planning, and recovery. Number one, there should be rebuilt surgical infrastructures. As you know, there is a lot of destruction in hospitals in every Sudanese towns, especially in Khartoum and Al-Fashir. So rehabilitation of hospitals, particularly trauma centers in conflict-affected areas, as I mentioned, in Khartoum and Al-Fashir and other countries that suffer this destruction. Installation of renewed energy for surgical theaters to ensure community despite great collapse, continuity of despite great collapse, and also train a new generation of surgeons, scholarship and exchange programs for Sudanese medical students and junior doctors to specialize in trauma, orthopedic, reconstructive surgery, and plastic surgery, collaboration with African surgical colleagues and universities to standardize training. Also, after stopping the war and peace come, national surgical and obstetrics and anesthesia plan. Sudan must adopt and update a national surgical strategy that prioritizes equitable access to emergency and elective surgeries. The plan should include investment in surgical research, workforce development, and data-driven monitoring. Also, after peace, surgeons in peace building, engagement surgeons and health professionals in peace building and reconciliation efforts. The act of healing, regardless of political alignment, creates a bridge toward unity. Also, after peace, strengthening local manufacturing, invest in local production of surgical tools, gowns, and sterilization equipment, will reduce dependency on foreign aid. Expand mental health support, implement programs to address surgeon burnout, PTSD, post-trauma stress disorders, and patient trauma recovery both during and after surgery. In conclusions, the story of humanitarian surgery in Sudan is one of courage, innovation, and resilience. Aimed war and destruction, surgeons are not only saving lives but also defending the dignity of humanity. The global community must recognize the crucial role they play and work together with Sudanese professionals to rebuild a healthcare system that serves all in peace, and in conflict. As we envision, of course, for Sudan, let us ensure that surgery is not a privilege, but a right, accessible, affordable, and safe for every citizen. I'm very thankful for everyone for attention, and I'm sorry for I'm not preparing myself well to this presentation because we are only 3 surgeons in the Madani and we have a lot of work upon us, and we hope for everyone of our surgeons to come back and shoulder our responsibility to build our town of Madani and our Sudan. Thank you all.
Thank you so much. Thank you so much. We actually extend our sincere gratitude to you, Mr. Adam, for sharing this inspiring experience with us today. Your story serves a compelling testament for dedication and exceptional resilience, staying till now in with Madani, with all that happening now. It's like that, reflecting high commitment to high values and serving for our lovely country. So it's our collective hope that the situation with Sudan will improve, inshallah, allowing the healthcare professional to practice again in a secure, constructive, and enabling environment. Now I invite you, participants, to for the discussion. The floor is open for your question, and please feel welcome to address any queries to Mr. Adam and Mr. Michael regarding any aspect of humanitarian surgery in the conflict. Maybe if you're still available with us, Dr. Michael, if I could ask you one question, a suggestion, and based on your experience, what do you think is the most urgent now priority to improve the trauma care in the humanitarian context today?
I think, yeah, I mean, hearing from presentation, very inspiring presentation from Mr. Adams. And this is a situation in most contexts. There's always a lot of needs, the scarcity of skills, and actually overwhelming needs at times like this. Often what you can do is to support and empower the people on the ground. And that's where you're going to get most impact. And what I've been thinking all these years is if you improve the financing system, even during the conflicts, probably you're going to get much, much more than most approaches. Okay. So I'm talking about things like community health funds, where in certain area, in a localized area, if there is a little bit of a very basic local financing system which can be supported to support, even if it's a private clinic, even if it's just a network of whatever surgeons or doctors are on ground, to make sure like they can be financed to do as much as they can. Then once you have improved the financing system, then the training will come, the skills will come, everything will fall in. So using pool funds or community health funds at this time. And then once things are much more calmer, they can be reorganized into national health funds or something else. And to be honest, it's very complicated. But again, as I said, financing the system and the training, okay, probably that's the most important thing to try and improve up things. Thank you.
Thank you so much. Maybe another last question in this panel for Mr. Adam. If you can share with us any example of how political or economic instability here in Sudan impacts the ability of delivering the surgical care, and maybe how can international surgical communities better support surgeons working in a fragile health system like Sudan? Mr. Adam, if you have heard me, are you still with us?
Abdelhamid, can you please repeat your question?
Okay.
Can
Yes, I can. So I was asking you if we can share examples now of how the political or the economic instability could impact like really the ability to deliver the surgical care. It's clear for us that's happened in Wad Madani. And maybe how can international surgical communities better support surgeons working in the fragile health system in Sudan?
Yeah, we need first of all we need the system that include the peace, what is very important to practice medicine, because there is war and there is injuries to or there is destruction of hospitals and the staff be threatened from soldiers or from any militia, and that there will be a problem to practice surgery safe. So firstly, we need to be safe in ourselves and our staff. Then we can improve our surgery with our limited facilities, and by more training of our surgeons, young surgeons, to be for scholarship in Africa or in Europe or even America, and that this need to be supported by the government, and we think so. And in the coming days or months or years, and also we need to be more with the non-governmental organizations to help our country, which needs this help a lot in every settings.
Yes. Much more thanks to you, Mr. Adam, and also thank you all the thanks for Mr. Michael. Thank you for sharing these invaluable experiences and insights on humanitarian surgery in the conflict zone. Again, it's like our GIST team, all the members here with us today send their warm greetings for you. And you are really truly loved and respected among the entire GIST community, to Mr. Adam, and we hope we are all back to Wad Madani again to meet you very soon, inshallah. From the bottom of our hearts, thank you, Dr. Michael, and thank you, Mr. Adam. Thank you so much.
Thank you very much.
Okay, so now by the end, this is it. We could say this is the end of this panel, the humanitarian panel. I can pass the mic back again to Wissam or to Nazar. The mic is back to you.
Thank you very much, Wissam. Can you please start? Your mic is muted if you're talking.
Now, can you hear me?
Yes, we can hear you clearly.
So, okay, welcome again to our last panel today, which is innovation and telesurgery, where we are going to explore more about how technology is reshaping the surgical care, since as we already seen that during the conflict, the access to safe surgical care is impossible. So the technology is trying to support and help bridging the critical gap and support the frontline teams and save lives when physical presence is not possible. And here we are trying to know more about this with the assistance of our honored speaker today, who is Dr. Nicholas Okumu, a leading orthopedic surgeon and healthcare leader in Kenya. He heads the orthopedic oncology unit in Kenyatta or at Kenyatta National Hospital. He serves as the CEO of Stratus Medical and brings wealth experience in surgery, leadership, and innovation. His background includes advanced training from Harvard and University of Washington, and he currently serves as 2024 Global Surgery Advocacy Fellow. So, Dr. Okumu, please join us.
Hello to everyone. Can you hear me?
Yes, we can hear you clearly. Thank you.
Thank you. Okay, I'd like to share my screen. Just let me know if you can see the presentation as well.
We can see it clearly, yes.
Yes, we can see it clearly. Dr. Okumu, we are very sorry for the delay.
It's okay. I think I understand. It's been a long discussion. And a lot of the information that I'll be giving is not new, and I'll try to keep it as brief as possible. So I was asked to talk about telesurgical consultations in conflict settings. And I'll begin by saying, actually, even if there was no conflict, there's already a surgical crisis, which is quite significant. As you well know, by now, over 5 billion people around the world lack access to safe surgical, obstetric, trauma, and anesthesia care. And in Africa, that actually translates to 1 billion people. And surgery has traditionally been neglected in global health conversations. And again, these are statistics that are not new. 30% of the global disease burden is surgical in nature. And already, even without conflict, we are losing over 18 million lives annually on the continent that could have been saved with appropriate surgical care. So we still need to advocate for that improvement in surgical access with or without conflict. But if you look at conflict zones in particular, the need for surgery actually increases. But the problem there is that the capacity also has collapsed. And it's often difficult to consult for the first casualties. And then again, infrastructure is affected. The things we need for teleconsultation, such as internet and so forth, are also affected. But if it is possible at all to connect with colleagues who are outside the conflict zone, it can help restore critical decision making. I'll just define some key terms quickly. Telesurgical consultation is essentially it's remote support by surgeons via digital platforms. It can be synchronous, that is in real time. So for example, video call during surgery, or it can be asynchronous, which means the communication is delayed. For example, sharing images or reports via tools like WhatsApp. You already know what multidisciplinary team means. And one of the examples I'll give, Proximie, is a real-time secure telemonitoring system, telementoring platform, which has video and AR capability. So I don't want to be the expert on Sudan. We have already had a lot of information on that. But from what I was able to gather, over 70% of the hospitals in conflict zones are now not operational. And like I've mentioned, the infrastructure has been affected. A lot of medical specialists have actually left, and there are few remaining in functioning hospitals. And then there is ethical challenges, sharing data and keeping it private, and also respecting patients' rights and wishes. So what I wanted to do is just give a few examples of how we use technology right now in my country, Kenya, where we can be able to consult virtually. The first one I'll give is actually what we do for our orthopedic oncology MDT at Kenyatta National Hospital, where I work. Cases are presented virtually, and now surgeons from peripheral hospitals are able to share their cases and get expert multidisciplinary input. So this improves patient management, allows for early referrals, and actually prevents mismanagement. And what we've done in this sense is that we have democratized the tumor board and opened it up to everyone, so that hopefully everyone can share and learn from that expertise. The second example I'll give is our use of actually platforms like WhatsApp, where we have what we call the Kenya Orthopedic Oncology Group. And in this group, we have experts from Oxford, the University of Iowa, Harvard Medical School, and others, who again now jump in to share expert input and help us with difficult cases. It's almost real-time decision-making, because we actually discuss these cases before any surgical intervention is done. And it actually encourages peer-to-peer learning and support across regions. And this is peer-reviewed surgery in real time. The third example that we use is something that was actually developed by Harvard Global Orthopedics Collaborative, and it's a global WhatsApp group. There are actually members from more than 153 countries. And here, any surgeon can share a case that is challenging to them and get a discussion that is across continents. And it involves both senior surgeons and trainees, so that we are benefiting from collective wisdom. So even in this setting, doctors from Sudan, for example, could be able to drop in their cases, whether they are junior or senior doctors, and access, for example, Harvard-trained eyes to give them guidance on what to do and how to manage patients specifically. Another example I'll give is our daily trauma reviews at Kenyatta National Hospital. And this started again with COVID, when we switched to virtual methods of discussing patients. But we now do it in a hybrid way. So there's actually in-person attendance, and others are able to join virtually. And every day we discuss the trauma admissions from the day before. And this also helps to help our residents to learn and to gain experience in management of cases. The next example I want to give is actually live surgical guidance using what I just mentioned, Proximie. And this one allows live recording of actual surgeons in different areas of the world doing their surgeries. And then faculty and students from anywhere in the world can actually join and see the case live, contribute to, in terms of guiding the process, and it allows a learning and peer review and all those things, so that hopefully surgeons with less experience can gain the experience and learn, and hopefully those ones and learn from people with a bit more experience. We are trying to actually make this more portable, because Proximie actually is a very advanced setup within a theater, but we have actually developed more portable tools with an AR headset, which can travel anywhere in the world. And we're actually piloting this now. And hopefully this will allow us to make this mission mobile. And then it could be used even in settings like yours where there's conflict, with the surgeon able to move from place to place more easily. So these are five examples I was given, and for the lessons I would take from this is start with what you have. WhatsApp is a good tool. It's fairly secure in the sense that everything is encrypted. So within those groups that you set up, if you agree to keep the information within there, then the patient data should be secure enough. And you can try to, if you need to anonymize the patient's information. Work in multidisciplinary teams, and simple tools like WhatsApp can have a big impact. Let's try and ensure confidentiality and ethical use of the data. And the tools we use should allow us to engage with surgeons further away in the diaspora, or even get distributed support. So even surgeons who have left Sudan and are in more stable settings can be engaged to contribute to sharing knowledge and mentoring those who are left behind. And again, this has been stressed throughout the day that documentation helps to monitor outcomes and scale responsibility. So as much as possible, even though the setting is difficult, try and keep data. And then don't wait for peace. Try and build systems that endure even in fragile situations. Awareness is important even for the general public, and as we said, for primary healthcare workers. So one of the tools I want to talk about, especially for my area of specialty, which is orthopedic oncology, is a website we have set up, which is www.sarcomalearning.africa. And here you can actually download a manual that gives you guidance on how to manage patients with tumors, musculoskeletal tumors, and also has videos and papers that talk about how to manage these cases. So this is a resource that is available to you. Make use of it as much as you can. So in conclusion, telesurgical consultations are not about technology as such. Even low tech can work. Even a text message, if you send it in, if you give clear enough information, it can be used to communicate. And in crisis, connectivity is care. For example, a surgeon like myself who is in Kenya, I am available to consult if we can set up the platforms. And consultation, I know, may be the most powerful procedure of all, because sometimes the surgical hands are not there, but a surgical guidance that we can give might be the difference between saving a life, losing a limb, and all those things that we have discussed. And I hope that as we progress in our conversations, we can build cross-border collaboration and make it African-led so that it can be a more permanent solution. Thank you for your time and listening to me. And I hope if you have any questions, I'm happy to answer them.
Thank you very much, Dr. Akumu. If anyone has any question, feel free to drop it in the chat box. Dr. Akumu, I'd like to ask you something. How can we ensure that the telesurgery does not widen the existing inequalities? For example, if we are working in a complex setting and we can, or we already have access to telesurgery, but people in other places, they are struggling maybe with referral systems, but they are not trying to access the telesurgery during the conflict. How can we manage the situation?
Something was mentioned about when we were discussing research and about helicopter research, dropping in and trying to collect data and then just disappear. I think along the way, we have to build long-term partnerships based on trust. And that's the only way it can work. If you trust that I am genuinely here to help you, and you can see that my interest is to make a difference, hopefully then you will be able to trust and consult me more over time. And I think that's all we can do, to build collaborations based on trust and then hopefully over time those become better. The other thing is just to make sure that as much as possible, we have talked about advocacy, awareness, just making sure that if we're generally then ready to help, that information is passed across as much as possible. And I think that's all we can do. The rest is generally up to then the people on the ground who have to decide that in some situations they need help. In some situations, talking to someone else, a different voice, a different perspective is useful. And hopefully over time, then we can build that collaboration that is based on trust.
Based on your experience, do you think when we have an emergency case, for example, can we manage like these, cases that needs rapid intervention, and in the same time we have to connect with people around and wait them until they answer or something like this? Have you encountered any of these experiences? Did you consider it as a problem in telesurgery?
Yes. For example, like I've mentioned, one of the groups we have, which is the Kenya Sarcoma Support Group, sometimes you can share a case and not get an answer maybe in good time. But hopefully if you have enough collaborators, that's something that over time can be overcome. For example, I might not be able to connect with someone in the UK right now because it's the middle of the night. But a colleague of mine in the US, right now it's probably just the middle of the day. So if you have enough of a network, like we've said, you should be able to overcome time difference and that kind of thing. So I think make sure you open it up enough and get enough partners from wherever in the world they may be. And in numbers, I think you have the strength so that there are no gaps in care. And then the collaborators need to also let you know the extent of their availability. For example, right now in Nairobi, it's, and I'm sure even in where you are, it's close to midnight. So someone who you want to rely on to help you needs to tell you when and where he's available, so that you actually then know the times to consult. So I think it's all about, like I've said, building partnerships based on trust, and then and a clear understanding, so that you are not, you're not getting gaps in care.
Okay. Someone is asking, what platforms do you recommend to use in remote areas or in remote telesurgery?
I think, to be honest, something like WhatsApp works very well, or Telegram or Signal work very well in remote areas where connectivity might not be that strong. But if you have a good internet infrastructure, then, or even what you're doing now, Zoom and other platforms can be used. So I would base the platform you choose to use on how connected you are. For example, I remember just about 2 weeks ago, I did speak to a colleague in Sudan, but we were actually speaking, I think he was calling me on a satellite phone, because at the time there was a challenge with the telecommunications network. So all he could do was make a phone call. But in another place, that maybe like today, I can see a lot of you on the internet, so it means the connectivity is better. So I guess I would say choose the platform based on how connected you are.
Okay.
If I may, if I can ask you just one question, sorry, Wissam. So thank you, Dr. Nicholas. I just want to ask about the telesurgery efforts that you're doing. Actually, we're having a telesurgery center here at the SSD. We are starting to make a new one. So we did our situation analysis, but we didn't start yet. I was thinking maybe you can help us with this thing to start the hub in Sudan, if you can. We did just little analysis in the remote areas in some states, and we think maybe we can start on WhatsApp. But I'm asking for your help if you can be with us in this project. Thank you.
100%, I'm available. I would say a lot of the work we are doing in Kenya is in collaboration with Proximi. which is an organization that's actually committed itself to improve the video connectivity and allow live video sharing. Like I said, their platform is fairly advanced. It needs to be pre-installed in a theater, but we are also working on a side project where we can develop more mobile tools. So I'll be happy to share and collaborate with you with that information.
Thank you very much.
I can see a
someone here asked,
question. Yeah,
yes.
continue.
What ethical considerations should be prioritized when implementing telesurgery, especially regarding patient consent, data security, and the surgeon-patient relationship?
Those are very important things. And the ethics that apply to sharing medical information should be the same. Patient consent is very important. So we need to actually inform our patients, even when we are consulting about them with people who are far away. We should be able to tell them that I am going to speak to someone else about your condition. The second part about this kind of platforms that we use for video sharing images, there should be some level of anonymity. So for example, when I share a video of a patient's limb, maybe we should obscure their, their face or something, so that they are actually still anonymous. And then data that is being shared across email, WhatsApp, that kind of thing, we should try as much as possible to keep patient identifiers out of it. You can share an X-ray without sharing the patient's name, for example. It still applies, and I think we need to be very careful how we share data, considering the patient's right to privacy.
Okay, thank you. Someone here is asking about, given your knowledge already in this field, can you describe the progress of this in Africa, the progress of use of telesurgery and its issues in Africa?
Okay. I will give you some local examples in Kenya. Kenya politically is divided into, or administratively, sorry, is divided into what we call counties. And there are some counties in Kenya who are actually building telemedicine as one of the ways to improve access to care. One of the leading counties in Kenya is actually called Murang'a County, and that's one of the ones I would recommend you actually benchmark with. They have a whole telemedicine platform so that patients, for example, with chronic diseases such as hypertension, diabetes, do not actually have to step into a hospital physically to get their follow-ups. So that is fairly advanced in our country. There are also private healthcare providers who are fully online, especially in big towns like Nairobi. So that is also available for us. And for example, in my private work in the company I'm building, we have built actually platforms where we can connect patients to delivery of medication and payment platforms like the insurances without actually ever stepping into a health facility. So those are all things we are exploring with technology. We are trying to even bring in aspects of artificial intelligence, for example, things like WhatsApp chatbots and so forth, to allow us to then conversate with patients and even serve larger numbers. So we are trying all these aspects to make this kind of teleconsultation more available to our patients.
Okay, thank you. Malaz here is asking, she wants to ask personally. Malaz, you can ask now.
Okay, thank you so much, Doctor, for your presentation. From my knowledge, especially Kenya has become very advanced when it comes to telemedicine and right now telesurgery, and it is moving towards telepathology. But I guess with the advance of AI in our current world, I am just curious, how would we like integrate AI with our current technologies to sort of advance our services?
My answer to you is that AI is a tool. It's not a solution. So AI will not solve all our problems, but AI can make a provision of healthcare much easier. So for example, in areas like radiology, and you've already mentioned pathology, AI is actually going to help us to process samples and images much faster. And actually, there's evidence that it is more accurate in some instances than human assessment. So those are areas where I could deploy AI. There's also an area of AI where we're using AI to help in clinical decision support, so that, for example, in the triage of patients, based on the history they're giving, we can actually direct patients to the right doctor, for example, if they need a specialist, rather than going through a convoluted referral process. AI can also help us optimize care, for example, allocating theater space for things like surgery and so forth. So AI is a tool. You just have to find where it fits best. So it will not solve every problem, but definitely it can be helpful in many aspects of healthcare provision.
Okay, I guess Hamdi have a questions.
Okay.
Yes.
So, hello.
Hello.
Hello, Dr. Nicholas. Thank you for your presentation and for your valuable experience in telesurgery. I have just question from your experience in telesurgery, especially in lower and middle income country. How receptive are the patients and the medical and surgical team itself to the technology and adaptation of technology? And what measure that we can use to help them to integrate this in our surgical system?
Okay. In a country like Kenya, even in I'm sure in your country in Sudan, the younger generation, let me say, is adapting to technology fairly quickly. So that is not an issue. They are fairly receptive to things like what we're saying, telemedicine and teleconsultation and virtual meetings and those kind of things. So and for the general public, I think it's all about how you create awareness and market products. So it's all about how you package and present the options you have. So and I don't think there's a lack of creativity in that sense. So how much the public will take up certain technologies will depend on things like availability of internet, of course, mobile penetration, how we adapt applications to local settings. But you can always convince people to use it if they can see the value in it.
Thank you.
Someone is asking, how can we join Proximie? I contacted the mail contact on the website.
Yes, Proximie should be available online, and I think connecting to them is fairly straightforward. They're interested in helping to improve that accessibility of video, video and AR. I keep forgetting what AR means. In terms of then improving surgical access and training. So I think the only challenge might be that in your country right now, there's that issue of the conflict, but definitely there are ways probably that can be overcome. And I'm sure they would be happy to help. If you we can over time we can help you connect with our surgical society, which is working in close collaboration with them, and hopefully then you can get a line to see how to work with them for this kind of project.
Thank you very
Thank you very much for your kind offer.
So thank you for your time. I think the questions were very engaging. I think I need to step out for a bit because I'm still I'm still working. But thank you so much for this opportunity to speak to you.
Thank you
You're
so much,
welcome.
Dr. It is our honor to be here with us today. Okay. Next. So everyone, I think you all are familiar with this photo. It has been trend for a while in the past couple of months, and we really curious about what happened exactly and what the challenges actually the surgeon faced during conflict and to perform surgery with absolute no facility and no electricity and so on. So it is our pleasure today to welcome Mr. Idris. He is one of our colorectal surgery, and he's actually consultant of general surgery at Bashir University Hospital, and has participated in many surgery in or within conflict area. So welcome, Mr. Idris. Can you tell us more about the challenges surgeons face to perform surgery and what the solution or suggested innovation to tackle these challenges? Thank you.
Thank you. Hi, hello everyone. Assalamu alaikum wa rahmatullahi wa barakatuh. It's a great pleasure to welcome you here today, all doctors, students, and nurses for this session. It is organized by Sudanese Platform for Surgical Development. And also I want to thank Sudanese Platform for Surgical Development for giving me this opportunity. And also thanks for their effort for continue educating and supporting medical staff. And hope I'll ask Allah to more success, inshallah. So we are talking about the surgery in conflict zone. We are talking about the procedures, surgical procedures that is did during conflict area, forces between two army, with limited resource and high volume of the cases. As you know, Sudan suffered a lot from this war, and also I want to take a moment to praise our hand in prayer and ask Allah subhanahu wa ta'ala to bring peace and ceasefire for our nation. Okay. So we have many challenges facing surgical procedure during the war. This challenges is divided into practical challenges or physical challenges. One of the practical challenges is a limited resource. This is resource of medical supply and infrastructure or post-operative care. Also, there is a security risk for doctors. Security risk for doctors. You know that doctors in the conflict area are at risk for injury or kidnapping or something like that. Another thing, the shortage of the trained doctors. You know, all the procedures I see in this session today I did with a medical officer or junior registrar or something like that. Because there is a shortage. One of the challenging is the shortage of the trained doctors. Other thing, triaging observation or patient selections with limited resources is more difficult. Right. The last thing is in practical challenges, the logistics. When you need to transfer patient from area to area, so it's difficult during war, something like that. Transportation it may take time or something like that. So ethical challenges, we're talking about the informed consent. Usually the patients during conflict area may be confused, or maybe without relative, or maybe illiterate. So we cannot able to take an informed consent for the patient. Other things is priority. How to who did take this, provide care. You decide who should provide care. So it's different from one to one. Because you are limited resource, it looks like you decide who's going to live and who's going to die because of the limited resource. Another thing challenging is data protection. We know documentation and recording is a cornerstone in the health system. So this documentation and recording will give us the magnitude of the problem, and that is open the eyes of the governmental or international organization. But this is not work during conflict area or conflict zone, because maybe for the military issue or something like that, or maybe no one of the forces need other one to know how many people are killed or something like that, or injured or something like that. So there is lack of documentation or something like that. Another thing, it is a standard operation or not. So the operation is done by a medical officer or junior doctor, and he's just saving the life of the doctor. But it's not, this is a standard operation for this patient. So this enter in the ethical challenges. Other ethical challenges, you may be forced by the other army officer to provide a care for this special patient or something like leader also, regardless of the other patient or something like that. So this ethical challenges. So we are going to, what is the solution? In Sudan, at the beginning of the war in mid of April 2023, many of doctors are sharing their number in social media for consultations. So like that, so it seems that is useful, and many of the people are get benefit for this consultation. Another thing, NGOs, organizations, they did a great work. Sudan, like in Khartoum, the supply of medical supply and these operations. So NGOs have a great offers in this forum. Other things, personnel. I think the doctors, our doctors, medical doctors or junior doctors did a good job or great job in this war. So this is the benefit of this war. Are highly trained and did operation should be did by specialists or consultants. The other solution we use it in Sudan, airdrop. We see that in the north of the Darfur, Fashik city. The flight of the army are dropping the medicine and medical supply to the area that cannot be reached through the ground. Worldwide, solution may be used as mobile clinic unit and telemedicine, and also training the healthcare in the local area, and also using all the drone for provide the medical supply to the area of the conflict. So that is challenges and solutions. In Sudan, what we did, and worldwide, what the literature say. And also I can take a new advanced technology in surgery, like robotic surgery. It's good for this issue, like in war, but it's not good for this war or conflict zone. We use for sharing professional skills, experience between others and such. But if there is good infrastructure, electricity and network, robotic surgery is a good thing in a conflict zone. I would like to share our experience in case we did remote surgery through the video call with the direct state. Patient 25 years old, mode of trauma, gunshot, abdomen. They resuscitated and performed the first operations, laparotomy, in a village, not in a hospital, in conflict area, in a village in Jazeera. Then we found multiple injury in the right colon and small bowel. They did right colectomy. 3 to 5 days, the patient developed anastomotic leak. They called me at 8 p.m. The patient have anastomotic leak. The fecal matter is coming through the drain. So I said, this is for reopening, because if you wait to tomorrow or something like that, this may convert to sepsis and lead to septic shock and become difficult to deal with it in this area and areas surrounded by the forces. So the plan is to open it. Their team is collected at the 12 midnight, and the situation or the challenges of this surgery. First, there is no theater, prepared theater, or the used as house prepared to be theater or health center, and there is no anesthetic, there is technician, and the operation are the medical doctor, and there is no anesthetic machines, and even there is no monitor, and there is no electricity. Using their mobile light, and also there is a network using their Starlink. Okay, even there is no gowning, something like that for covering the patient. Anesthetic drugs only, spinal anesthesia, morphine, and some other ketamine used for it. The plan is to do colostomy to convert this sort of infection outside to guard against infection. So we made a video call for 2 to 3 hours until we finish the operations. And we have saved the life of the patient, and the patient is now alive and well. Only there is small paresthesia in the lower limb because of the exit of the bullet from the paraspinal side. So this, my experience, all our experience in the war. I finished. Is there any question? Ila?
Thank you so much, Mr. Idris. This actually insightful, and like from someone who is actually working and suffering from these challenges. So can you tell us more about the remote consultation you use during surgeries in general? Like Dr. Nicholas was talking about using normally the WhatsApp group, maybe. So how do you tackle this? The remote the WhatsApp group, the usual WhatsApp. So
yeah. Also, through the WhatsApp, video calls through the WhatsApp. This is the only I use it for the operation or something. Yeah, operation is not more, but it's like wound or something like that. We send through the WhatsApp chatting or something like that, and video call. That is only available, or is only the video calls through the WhatsApp.
Okay, perfect. Does anyone have any question? Please unmute yourself or drop it in the chat.
Sorry, I have a question to Mr. Idris. Mr. MashaAllah, كان عندكم you had experience with doing surgery through the phone يعني, or when you are in other place. يعني, can we expand this experience? يعني, can we make it like يعني, يعني, can we make guidelines for this and make it a usual practice in areas where we cannot reach out for those يعني, who are in bad situation? يعني?
Yeah, you can, yes. This operation also, yeah, it's not video call only. Also, I share the photo. Please look like that, do like that. Also. Many times I share photo, sometimes video call. I think this is accessible, and I have no problem to share my experience with other area in conflict. To do technical in conflict zone to the video call, just for saving the life. And this group of doctors, they did more than 22 operations. Most of them are trauma cases, like all CBD cancer. They do great job in saving the life of the patient until they refer it to other specialty. And some there is a definitive surgery, some are there is a primary surgery or like damage control surgery. They did a great work, and we try to publish or to write these cases. When we write it, we can present it if there is a chance to the platform.
Well, Doctor, actually, I had a question on like how do you actually prioritize patients in resource scarce environment where there are multiple casualties with varying level of injury?
So this depends to your resource. You know, what you have from the resource of the medical supply, you know about your resource. Then you can categorize the patient. In general or in a normal setting, categorize patients. This patient or are like in color. There's a green color, patient working. And yellow, patient smiles, and red, this patient is critical, and black, this patient is dead. So the most of the benefit in trauma case, you work in a yellow zone. Okay. Red zone, you take more time and more your resource, and you don't know what is the effect of this. So the most often you get in the yellow zone. Patients have injury, but it's highly susceptible in life or killer. And with a limited resource, you blame with your resource and your graduate.
Okay, and how do you by using remote consultation and those tools you mentioned, like WhatsApp group and video calls, how do you ensure the patient confidentiality and data security? when using this digital communication, and
You mean-
to avoid the legal issues, maybe after doing surgery, like the consent and those things.
You mean using this case as a presentation here now?
Sorry?
You mean the confidentiality of using this as a case I'm presented here now, or do you mean-
No, like in general,
Yeah.
taking consent and share their information,
So this is-
or
This is one of the ethical of the surgery in conflict zone. And you believe there is a benefits. This patient will go to benefit from this surgery, so are not going to wait for any form of consent or something like that. Is the patient benefit for surgery or not? Is the patient will get benefit for surgery and go? Regardless, one of the ethical challenges.
okay. So we have a question here from Rimaz. She said that that is amazing and you really did a great effort. She's asking about if you have faced new surgical cases or conditions that did not exist prior to the conflict, or they are just the usual cases. Did you hear my question, Steph?
Sorry, again?
Yeah, she asked about if you faced or if you operate on new surgical cases or new condition that you didn't operate before the conflict, or they are just the usual cases.
If the procedure or the surgery is not familiar for me, the first time for me, I will consult other ones to conduct the video call or to contact with this doctor to guide him. In conflict zone, we are not talking about the standards. We are not talking the life saving. Okay. So the doctor in the conflict zone, they did who they can do. Another thing is that can contact other one to help him. So if I cannot help, I can share with other one to help him to come back or to give him advice or to make a video call to do a surgery.
Okay, perfect. Okay, the last question, or it is not question. We want you to give us like the lesson learned or advice for all surgeons out there and all aspiring surgeons, like a last takeaway message.
Okay, because what I see in this world, the junior doctor is doing a great job. For junior doctor, I ask him to join more in emergency procedures, to do more operation, to see what is the different type of surgery, something like that, and to be familiar with all the emergency surgery. So another thing, trauma like Atlas, which is conducted by American Atlas, advanced trauma life support, should be taken by any doctor, especially junior doctors. And it's not only the surgeon, even other subspecialties, you should have take this course. Trauma courses should be for anyone, doctor, not just surgery. That is all.
Okay, perfect. Actually, we are planning to conduct a course about basic life trauma support. So just follow us if you are interested. We will announce for this course soon. I see Hamdi is raising his hand. Can you please unmute yourself?
Thank you, love. Thank you, Mr. Idris, and great appreciation for this valuable presentation and experience. And glad to see you back joining us in the city platforms. My question is, as you know, in our settings is very complex, and we have many area we need to work on it in order to make the telesurgery and application of those innovations that you see. And what is the most critical and the most things that you see from your experience we need to invest on it, like robotics or improving the network access or improving like building telesurgery centers, or what can you see from your experience is most critical issue that we help us to make the telesurgery reality in Sudan, conflict sitting like in our country?
Yeah, I hope we're not going to need this telesurgery for war again or something like that. And the best thing, I think, is the robotic surgery. And that's need a good infrastructure from electricity and network system. Surgery can done by experienced hands from different country, and that is the good. But the robotic surgery now is applied for sharing experience, like one from America to get operation from one from Asia, and so sharing experience. But I think it is a good telesurgery in conflict zone. If there is infrastructure is good, like electricity and network. And that's not need for us. Yes, we at the beginning, we need to bring this machines or this device, and the surgery will done by other one outside until they have courses and have training people in robotic surgery. And also mobile clinic, it's good idea. It's not available in Sudan so much. Also, the one thing we can benefit in this war, as I said in conflict zone, for supply, I mean the drone, uses of the drone for supplying of the medical device or medicine or something like that. Drone still is that have a chance, can be used in Sudan for supply. This time, so robotic in the future.
Okay, perfect. Thank you so much. It was a very nice presentation, and we appreciate your time and your effort to make this happen. Thank you so much.
Thank you. Thank you. Thank you.
And yeah, we came to conclude this second African Global Surgery Forum. We gain a perspective on insights from Sudan, Kenya, Tanzania, South Africa, Rwanda, Liberia, and finally, United States of America. And we hope you enjoy this and you get a good perspective and good tackle this real situation of conflict and surgery in Sudan. Thank you so much. And thanks also to the Jazeera Student Surgical Societies for their invaluable collaboration and their organization this forum with us. Thank you so much. Wissam.
You are pretty welcome, Ms. Elaf. It's our pleasure to work with you. So dear participants, we would love to inform you that we have extended the deadline of the abstract submission. So now you have access to submit your abstracts until May the 28th. And yes, let's say that we have some sort of a surprise for you that we are going to share our journal, which is going to be a collaboration between our research and global surgery cells. It's going to be something more interesting if you are interested in research and if you were with us in our first panel. So I hope that you enjoyed our first day in Global Surgery Forum, and we are waiting for you in our last day on May the 30th. Thank you again, and see you again in about 5 days' time. Goodbye. Sorry for making it very long.
Thank you very much, everyone. Goodbye.